All right, can you guys hear me? Have a washing machine going in the background. All right, good deal. All right. I'll probably give it like 2 or 3 minutes for everybody to get in. Okay. I think that might be everybody that's coming right now. I thought Bailey was coming, but I don't see her in here. Let's see. All right, we can go ahead and get started if you guys are ready. And it should be open where like people can join in after too. Okay. So I have GroupMe pulled up on the computer. If you guys can't hear me or it starts cutting out or something, you can send me a message in there and I should be able to fix it. Okay. All right, so we're starting in chapter 8 for the ATI book for maternity. And I know that Miss Shawn said that she was going to swap over to the other book that we used in the first semester. We haven't gotten anything else from her. I don't know if you guys have or not, but our class has not gotten anything saying what chapters to look at or what she wanted us to review. With that being said, I think she's just going to stick with ATI unless we get something between tomorrow and Monday, and I feel like she's probably just going to call it ATI and let that be it, because she's not going to test us on something that we didn't go over. And if she didn't specify what she wanted in the other book, then she's not just going to spring that on us. So This washing machine just keeps getting louder. Okay. So chapter 8 starts on page 53, and this is the medical conditions. So when we say cervical insufficiency or premature cervical dilation, this just means that your cervix is dilating too early. You're getting ready to go into labor too early. So it's a variable condition where expulsion of products of conception occurs, and that just means that your water is going to break too soon. It's thought to be related to tissue changes and alterations in the length of the cervix. So the length of the cervix, meaning as birth is progressing, you can feel that push down. So when you do a physical exam, you'll feel that cervix the farther along that birth is happening. So your risk factors are going to be any kind of cervical trauma that you have had, whether that be you've had a birth before, you've had any tears during a birth before, in too many dilations, curettage or biopsy, curettage for biopsy. And curettage is the scraping of the inside of your uterus. So if you've ever had a D&C, they have to scrape everything out of there. This would be a risk factor for cervical insufficiency. If you've had any cervical procedures involving the cervix, short labors, pregnancy, loss in early gestation, so you had like a really, really early spontaneous abortion, or advanced cervical dilation earlier weeks of gestation. This can also, another risk factor for this can also be utero exposure, y'all, it's late, to diethyl stilbestrol. And this is a chemo agent. I try to Google or look up any word that I don't know because I promise you it will help when you get to the test. Which reminds me that Callie has made I think it was an 80 question like vocab test for 8 through 13. And I'm going to post that to the website as soon as we get off of here. Pretty much, if you can work your way through that, you're going to have an easier time with these. So if you can make time to do that tomorrow, you'll be more set. I promise knowing vocabulary changes a lot for these tests. Okay, so the findings that you're going to see with cervical insufficiency would go along with pink-stained vaginal discharge or bleeding, which was one of her things that she hit on quite a bit, so I would definitely know that. Possible gush of fluid or rupture of membranes is what we're going to keep seeing, and that is just your water breaking really early. Uterine contractions with expulsion of fetus, so we're shooting out and we're not ready yet. Or postoperative cerclage monitoring for uterine contractions, rupture of membranes, and manifestations of infection. So cerclage just means to like tie off something, basically. And we're going to see that in the next paragraph. Under diagnostic and therapeutic procedures, so obviously we're going to have an ultrasound. We're going to try and see what's going on in there first. It should show a short cervix, meaning that we're, farther down, less than 25 millimeters in length. Presence of cervical funneling or beaking. And when I think of that, if you Google a picture of your cervix during the birthing process, it just looks like a beak facing down. Or effacement of the cervical os indicates reduced cervical competence. Wow. Okay, so effacement, when you're dilating, the bottom of your cervix is going to get thinner and it's going to widen. So thinning and widening. So the widening is your dilation and the thinning is your effacement. So widening is your dilation and then thinning is your effacement. Then you have a prophylactic cervical cerclage. This is another procedure that you can do, and that is just tying off the tip of the cervix until you are ready to have a baby. So if it's coming too fast, it's going to happen too soon, they can kind of tie it off. I just think of like a rubber band put around the bottom of your cervix to keep you from having that baby so early. Now, if they tie it off between 12 and 14 weeks, you'll remove it between 36 and 38 in later stages. So your nursing care for almost everything is going to be very, very similar. And I try not to spend too much time reading the same thing over and over and over, because then you get to the test and you just remember that one thing and you didn't really hit on what we call the zebras. So an instructor that we had before would tell you to look for the zebras because you can memorize the same thing for every chapter all the way through. It's not going to help you when you see something stand out on the test and you're like, wow, well, I hit on the stuff that I did know all this time and I didn't look over the things that I really didn't. So The nursing care for cervical insufficiency is you're always going to want to look at their vital signs. It's best if you try to get a baseline first, but always vital signs. So monitor client support systems and availability of assistance if activity restrictions or bed rest are prescribed. So you want to make sure that your person has a person to hold them accountable for bed rest, to chill out, because as Ms. Shawn has said before, gravity works. So if our patient's up running around doing a bunch of crazy stuff, lifting, doing wild things, this is going to continue. It's just going to keep happening. They're going to have this baby early. So we want them to chill out. Is their support system going to support them in the correct way? We're going to monitor vaginal discharge. Why? Because we want to look for this pink stain vaginal discharge or bleeding. That's going to let us know what's going on. What's the color? Does it smell? How much is it? How much is there? You're going to monitor your client's reports of pressure and contractions, because if it hasn't stopped, they're going to keep having contractions. And that also lets us know that we need to continue on and doing something else to stop it. And then vital signs is your last thing. So your education for your client is bed rest, bed rest, bed rest. Chill out. We're not trying to push this baby out any quicker. Encourage hydration to promote relaxed uterus. Dehydration stimulates uterine contraction. So through each thing that you're going to see in this chapter, hydrate, hydrate, hydrate. Avoid intercourse. I just put no sex on there. Monitor for cervical or uterine changes, meaning you're going to do the physical exam to see your beaking, how far down you are. And your patient can also do this, because in earlier chapters when we talked about conception, we as women can check our cervix and see how everything's going along if we're trying to get pregnant, when we can look at, when we might be ovulating, that kind of thing. So they can do those things at home. If we send them home after we've done this cerclage, they can go home and see, things are kind of moving along, things are moving down, and they can come back in and we can, deal with that then. So your client education would involve that. We also need to let them know about the cervical cerclage, which is pretty much the same exact paragraph that we had up there. If they do it at 12 to 14 weeks, we're going to remove it at 36 to 38 weeks. I'm sorry. So they need to know you're going to have to come back in. We're going to have to take this off. For health promotion and disease prevention, you need to report findings to the provider as far as preterm labor, rupture of membranes, infection, strong contractions less than 5 minutes apart, severe perineal pressure, and your urge to push. So your patient tells you, hey, this stuff is going on, you let somebody else know, because that means we need to do something farther. Your nursing actions reinforce the client to have follow-up observations. They're going to have to come back in and have it removed and anticipate removal. All right, so we're on page 54. Hyperemesis gravidarum. The way that I remember this is hyper meaning a lot, emesis meaning vomit, throwing up, and gravidarum, we Googled, doesn't really have a word. If anybody else can find that word, I would love to know it. But I just think of grand throwing up, a lot of puking. So this is, take your morning sickness and multiply it times 10. It's going to be awful, awful. So it's excess nausea and vomiting, possibly related to HCG levels. So when you do get pregnant, you take a pregnancy test and it's going to show you that your HCG levels are up. So sometimes this will cause a patient to have this hyperemesis gravidarum. It's usually prolonged past 16 weeks of gestation, or that is excessive and can cause weight loss, dehydration, nutritional deficiencies, electrolyte imbalances, and ketonuria. There's a risk to the fetus for intrauterine growth to kind of be stunted, so small for gestational age or preterm birth if the condition continues. So this happens because of a high HCG level. It's usually going to last longer than 16 weeks, which is, your morning sickness is not that. And it can cause a lot of issues for the baby. Because if you're not getting nutrients, if you're not getting taken care of, the baby's not getting taken care of. The two of you are one. So your risk factors are going to be if you are younger than 30 years old, if you have many babies, multifetal gestation, gestational trophoblastic disease, psychosocial issues, and high levels of emotional stress, which, us women are usually stressed anyways. Hyperthyroidism or any kind of disorder. If you see some kind of disorder, that's usually going to be a risk factor. Diabetes, gastrointestinal disorders, I usually think like GERD, something like that, or family history of hyperemesis. So if your mom had it, your grandma had it, chances are you probably will have the same issue. So your findings in this physically are going to be excess vomiting for prolonged periods. So just, this ain't morning sickness, I run to the toilet and it's over with. Like, this can be all day, day in, day out. Dehydration with possible electrolyte imbalance. So you're not keeping that in. You're getting rid of everything that you've ingested, anything that you've eaten that's been healthy that you're trying to give to your baby. That's out the window. Weight loss, and somewhere in here, I don't remember where I saw it, but I do remember her saying it, weight loss of 5% or more. So this isn't just like, I lost a pound today because I have morning sickness, for a couple of days or something like. This is extreme. Increased pulse rate, decreased blood pressure, poor skin texture, and dry mucous membranes. The last three is going to be because your fluids are gone. So you're going to have an increased pulse rate. Your body's trying to compensate for the loss. Decreased blood pressure because you don't have anything filling your veins. I mean, you think about it, your veins, you need something to touch both sides. If you're dehydrated, you're not hitting the level that it needs to be at for you to have good perfusion. Poor skin texture and dry mucous membranes because you're getting rid of all of the fluids that you have. So hydrate, hydrate, hydrate. I guarantee you there's going to be a question on that test. And these aren't going to be not, defining terms. She's going to put you in a situation where you have to choose what is the best for your patient in this situation. So your lab tests are going to be a UA because we're looking for ketones and acetones, or the breakdown of protein and fat. So if you know anything about ketoacidosis, you know that when you're on a keto diet, you are trying to burn as much fat as you can as quick as you can. Well, eventually your body's going to run out of that fat to burn, or it's going to stop using it and it's going to start burning muscle or burning protein. So if you have elevated urine-specific gravity, it's because you don't have a lot of fluid in your body. So your urine's going to be more concentrated. It's going to be dark. It's going to be yellow. It's probably going to smell. It's the most important laboratory test is a positive ketonuria, because if you have ketones in your urine, we know what's going on. Chemistry profile revealing electrolyte imbalances. So sodium, potassium, chloride reduced from low intake. Metabolic acidosis, secondary to starvation. So starvation, like, this is serious. You're losing all of this. Metabolic alkalosis due to excessive vomiting, elevated liver enzymes, and a bilirubin level. Also a thyroid test indicating hyperthyroidism, which we saw earlier was a risk factor. So if you have hyperemesis gravidarum, they may run the thyroid test to be like, oh, okay, this is where this came from. They're going to do a CBC. So elevated hematocrit concentration because of inability to retain fluid results in hemoconcentration. So if you have less fluid in your body, everything's going to be more concentrated. Your urine will be more concentrated. Your blood will be more concentrated. So it's going to be thick. So your patient-centered care for this is you're going to monitor eyes and nose. You want to know what's going in. You want to know what's coming out, and they should be the same. You're going to evaluate skin texture, mucous membranes, monitor vital signs, monitor weight. Weight should probably be a question as well, because weight is the most accurate telltale sign for things like this. And you want to have your client remain NPO until the vomiting stops. So you're kind of like pulling them back, starting over. For medications, she said, the PowerPoint said B12, but she said to go by the ATI book, and that's B6. I would go by B6 because it's in the book. You may see both on the test. I'm not sure, but no matter what, we bought these books. I would go by the book because you can always appeal that. Give IV lactated ringers for hydration. So they may give LR, they can give normal saline, stuff like that. You want to bulk up the fluids that are there. You can give pyridoxine. I'm super bad at pronouncing these. I can spell stuff all day long, just can't say it. And other vitamins, supplements as tolerated. So you're taking this to build yourself back up. You can use an antiemetic medication, metochlopramide. That's going to be in here quite a bit, so I would know that medication. That is for uncontrollable nausea and vomiting, so it's an antiemetic. Use corticosteroids to treat refractory hyperemesis gravidarum. Okay, so we need to know those medications. She's probably going to ask those questions. She did hit on that quite a bit. Okay, so for your client education, you're going to advance to a diet of clear liquids and bland foods once the vomiting has stopped. So NPO until your vomiting has stopped. And then once it's stopped, then you work your way up to clear liquids and bland foods. So that would be frequent small meals, and you're going to want to start with like dry toast, crackers, cereal, then move to the softer diet, so maybe like mashed potatoes or something. And in severe cases, like very, very severe, we can do enteral feedings per feeding tube or total parental nutrition. But that would be like end all be all. That's an emergency. Okay. So then we're going to look at iron deficiency anemia, which I feel like we've hit on quite a bit. This can occur during pregnancy due to inadequacy of maternal iron stores and consuming insufficient amounts of dietary iron. So remember, she said nowadays we don't eat what we're supposed to. We don't take in the things that we should, so we're not getting that, and a lot of us aren't supplementing it when we don't get it. So the risk factors for having this iron deficiency anemia would be less than 2 years between pregnancy, because your body hasn't had a chance to work itself back up. It hasn't had a chance to kind of restore to that norm. Heavy menses, so if you have somebody that already has a heavy flow when they come in, well, their iron's already low. And so it's going to be even harder for them to maintain something when they're trying to take care of an infant as well. Diet low in iron. We don't eat the way we're supposed to. And unhealthy weight loss programs. She said all diets are bad diets, and that, you can eat a cheeseburger all day long. It's just about moderation, and it's about filling the gap when you're not getting what you're supposed to. So your expected findings are going to be fatigue and weakness, or craving unusual food. And pica is on here. When it talks about pica, she's talking more about like the ice chips, things like that, because people that have anemia usually crave ice or like water. It's like your body knows what it needs. So when you see pica, if it's on the test, it's probably going to be ice chips. Your laboratory tests are going to be hemoglobin less than 11 milligrams per deciliter in the first and third trimesters, and less than 10.5 milligrams per deciliter in the second trimester. Hematocrit less than 33, and blood ferritin less than 12 in the presence of low hemoglobin. She didn't really super hit on numbers, but I would try to find some way to memorize that if you can. She didn't seem like a numbers kind of person, but I could be wrong. So your patient-centered care, as a nurse, you're going to recommend iron intake for pregnant clients as 27 milligrams a day. 27. I am 27 years old, and I also have anemia. That's the truth. So think of me when you think of this. Your patients, I need to be taking 27 milligrams per day. Prenatal vitamins usually contain 30 or more. So if your patient's taking a prenatal vitamin, they may not have to take this iron supplement. If the mother has an iron deficiency before, you may ask her to increase the dose of 60 to 120 milligrams because they're already low when they came in, that kind of thing. So for dietary intake of foods rich in iron, you're going to look at legumes, which is beans, dried fruit, dark green leafy vegetables, and meat. So anytime you see a test, it's always going to be green leafy vegetables. I don't know, she might switch it up, but it is always green leafy vegetables. You want to educate your client about ways to minimize GI adverse effects. So your medications for this are going to be ferrous sulfate iron supplements, and you're going to take this on an empty stomach. Why? Because the absorption is quicker. You're also not going to take this with milk. No milk with iron, because it is going to decrease the absorption. But you should take it with orange juice. This will help absorb it. So orange juice on an empty stomach. You need to adhere to a diet rich in vitamin C containing foods to increase absorption and increase roughage and fluid. And a lot of people, I think we had a quiz a while back, and roughage was in it. Roughage just means like greens, leafy vegetables, that kind of thing. So when I think roughage, I think of like a cow in a field eating hay. And that's probably what we need to be doing with vegetables. So the parenteral iron therapy is for pregnant clients who cannot tolerate oral iron, because some people, it makes them really sick. I should be taking that, and it makes me feel horrible. And I also don't take it the way that I'm supposed to take it, but, So you could have it, put into your body forcefully. And that also goes for severe anemic clients who they can receive blood transfusions. So this can replenish it, but that's like a more severe thing. And we always want to start with the least invasive first, which would be take this pill. All right, so now we're going to look at gestational diabetes mellitus. So this gestational, meaning while you're pregnant, you get diabetes. Doesn't always happen, but some people do. So GDM is an impaired tolerance to glucose with the first onset or recognition during pregnancy. The ideal blood glucose level during pregnancy should range between 60 and 99 before meals or fasting. So you haven't eaten, it should be 60 to 99. It should be less than or equal to. The washing machine sounds like it's about to take off the roof. It should be less than or equal to 120 milligrams per deciliter 2 hours after meals. So after you eat something, it should be higher all the way up until like 2 hours after your meal. The findings can disappear in a few weeks after delivery, or they can stay forever, and you can just keep diabetes. Approximately 50% of clients that develop type 2 diabetes mellitus approximately 50% of clients will develop type 2 diabetes mellitus later in life. So half of us keep it, half of us won't. So your increased risk to your fetus because of gestational diabetes mellitus would be macrosomia, which is just a big old baby. You got a big baby. Birth trauma, you had to pull and yank and squeeze and do all kinds of wild stuff to get that baby out. Electrolyte imbalances, and neonatal hypoglycemia. So when you have gestational diabetes, it can cause your baby to be large. It can cause there to be a lot of trauma when giving birth. It can cause electrolyte imbalances because everything's out of whack for you. It's going to be out of whack for them. And neonatal hypoglycemia, because it's hard to gauge that. You're having issues with that, and your baby might be smaller because of that. Infections, urinary and vaginal, related to increased glucose in the urine and decreased resistance because of altered carbohydrate metabolism. So we're not metabolizing things the way that we were before. This can cause an infection in your urine or your vagina. Hyperemesis, I've had such an issue with that word, which can cause overdistension of the uterus, placental abruption, preterm labor, and postpartum hemorrhage. So hyperemesis is too much fluid in the amniotic sac. So if there's too much fluid, it's going to cause the uterus. It can overdistend. It can get too big, kind of like when you hold your pee for too long and your bladder overdistends. That's what this does to your uterus. Placental abruption, meaning that your placenta detaches from the wall. Preterm labor, it can send you into labor too soon if you have too much fluid. And it can cause postpartum hemorrhage because you've stretched that uterus out to a point where it's more difficult for it to contract back afterwards. Another issue would be ketoacidosis, like we were talking about before. So from diabetogenic effects of pregnancy, increased insulin resistance, untreated hyperglycemia, or inappropriate insulin dosing. So if your patient is not taking care of their diabetes the way they're supposed to, this can happen. If they've never been treated for hyperglycemia, this could happen. All right, then we have hypoglycemia, and we're still an increased risk to fetus. Caused by overdosing in insulin or skipped or late meals or increased exercise. So your baby could have hypoglycemia because you're overdosing in insulin. You're using too much of it. You skipped or didn't eat a meal, so now that's thrown out of whack. Or if you're increasing exercise, because you got to think about the stuff that you're burning off, and then are you replenishing that? Are you taking too much insulin? That kind of thing. Hyperglycemia, which can cause excessive fetal growth or macrosomia. So if you have too much sugar in your body, it can cause your baby to have too much sugar in their body. So you will have a big old baby. So your data collection, you're going to look at your risk factors for the risk factors for you to have gestational diabetes mellitus. If you're obese, you're more likely to have it. If you have high blood pressure, you're more likely to have it. Glycosuria, more likely to have it. Maternal age older than 25, so would be likely to have it. Family histories of diabetes, or previous delivery of an infant that was large or stillborn. So the expected findings in this is if you have hypoglycemia, if you have a low blood sugar, you're going to have nervousness, headache, weakness, irritability, hunger, blurred vision. All these you would see in a non-pregnant person with diabetes that has hypoglycemia. This is pretty much going to be the same for whether you're pregnant or not. Hyperglycemia, polydipsia, polyphagia, polyuria, nausea, abdominal pain, flush, dry skin, or fruity breath. Fruity breath is going to be your key for any time you take a test and you're talking about hyperglycemia. That's your zebra. That's the one you want to pick. Your physical findings are going to be hypoglycemia, shaking, clammy, pale skin, shallow respirations, rapid pulse, hyperglycemia, vomiting, excess weight gain during pregnancy. So these are the things that you're going to see if you have this during pregnancy. Your laboratory tests, again, there's a bunch of numbers here, and I will do my best to try and memorize those the best that you can. But I had trouble for a little bit trying to differentiate between the tests. But your glucose screening test, 1 hour glucose test, you are going to load your patient up with 50 grams of oral glucose. So when I think of loading them with oral glucose, I'm thinking give them a 50-gram piece of sugar candy, something that had 50 grams, followed by a plasma glucose analysis 1 hour later performed at 24 to 28 weeks. So I'm 24 to 28 weeks pregnant. I'm going to go in for this glucose screening test, 1 hour glucose screening test, and they're going to give me 50 grams of sugar. And then afterwards, they're going to test. A positive blood glucose screening is 130 to 140 milligrams per deciliter or greater. So additional testing with a 3-hour oral glucose test is indicated. So if I come in at 24, 28 weeks, they load me up with 50 grams of sugar and give me a test 1 hour later, and it's 130 to 140 or greater, they're going to be like, okay, we need to come back in 3 hours and test you again because you're probably going to have gestational diabetes. And you do not have to fast for the 1 hour glucose screening. You do not have to fast for that one. The oral glucose tolerance test, you should fast overnight the night before. No caffeine, that would not do for me. And abstinence from smoking or 12 hours prior to testing. I don't know if she's ever gone over this with you or not before, but when you are in PO or you're fasting, smoking is considered food because it just is. Ms. McGehee has told us if you are going in for a surgery and you have smoked a cigarette within the time frame that you are not supposed to be eating, they will not do that surgery. They will not do it. So that's why it's telling you to abstain from smoking 12 hours prior to the testing because you're fasting. You're not supposed to have this before you go in. So no food, no caffeine, no smoking for 12 hours prior to the testing. A fasting glucose is obtained and 100 grams of glucose is given. So they're going to load you up with 100 grams of sugar for this test. And a serum glucose level is determined at 1, 2, and 3 hours following the glucose ingestion. So I come in, I haven't smoked my cigarette, I haven't had my caffeine, and I haven't eaten overnight. 12 hours prior to the testing, they're going to give me 100 grams of sugar. So they just gave me a bunch of cake icing. We'll say that. They're going to test me at 1 hour, 2 hours, and 3 hours. All right, so the presence of ketones in urine to determine severity of ketoacidosis. So depending on how much ketones you have in your urine is going to be dependent on how severe this is, and that will determine how they approach it afterwards. So your diagnostic procedures are going to be your biophysical profile to ascertain fetal well-being if non-stress test is non-reactive. So biophysical profile was like 3 or 4 questions on the last test. If you have not looked at that, I would 100% go back and look at it. I'm going to go back and look at it, but it's kind of like your APGAR scoring. So you're just looking at the well-being of the fetus and trying to determine whether or not it is going to be viable. You give it a scoring, and I do know that above 8 and above is we're good to go. I'm going to stop for just a second. I'm checking the group me. Okay. And I see that she just sent some kind of notification out. I'm hoping it's for the test. Nope, maybe not. Okay. Do you guys want to take a break? We've been going for like 35 minutes, or do y'all want to keep pushing? Yay! She posted a study guide. Okay, I'm gonna look at that real quick. Sometimes my notifications don't want to come through. Ooh. Okay, y'all, this is gonna be great. So if you haven't looked at your stuff yet, she said, I know that you all have been waiting all day. Sadly, I must report no luck in gaining enough space to add PowerPoints on 11 through 13. However, I do assure you, if you followed your ATI book so you can look at the book, what takes you all 20 to 40 minutes to read and take took me 9 hours to put together today. As a review sheet, key here is how you use it. On the left will be a word that is subject on the test. The number that follows the word indicates how many questions pertain to that subject. There are 5. Select all that apply on the test, and the remainder are multiple choice. Good luck. So that's cool. I've never seen a study guide like that before. But now we'll know what to hit on. Yeah, this is exciting. I've never had a study guide like that before. Okay. Let's see. All right. Are you guys good to keep going on here? All right. Okay, I'm gonna continue on with this, and we'll probably take a break at the end of 8. That way you guys can go to the bathroom, get yourself together, whatever you gotta do. All right. So we stopped at biophysical profile. I'm gonna have to look at her thing and see if she put that on there, but I know before she hit on it. Amniocentesis with amniotic fluid. Phosphatidylglycerol is used to measure and determine the fetal lung maturity. So know that you do an amniocentesis and use this to measure whether or not your fetus's lungs are appropriately maturing. We're going to do a non-stress test to monitor fetal well-being. And then your patient-centered care, you're going to monitor their blood glucose, obviously, and you're going to monitor the fetus. Let's see. Let's see. Oh, okay. I can see the comments on the video now. All right, I hear. All right, good to go. Yeah, I can see them on there now. I didn't have it pulled down. Okay. So for your medications, in contrast to clients who have type 1 diabetes, clients who have gestational diabetes are managed initially with diet and exercise alone. So if glucose levels are persistently high, insulin is begun. So for gestational diabetes, we're going to try not to do insulin. We're going to try not to mess with that. We're going to try to correct it with diet and exercise because insulin is more of like a permanent, unless it becomes serious enough, and then they'll start using that. Oral hypoglycemic therapy is alternative to insulin in clients who have gestational diabetes who require medication in addition to diet for blood glucose control. Most oral hypoglycemic agents are contraindicated for gestational diabetes, but there's a limited use of glyburide. Provider will need to make the determination if these medications are used. Yes. I think I have that paper in my backpack, and I can send that as soon as we get off of here because I need to look over it too. All right, for your client education, we're going to perform daily kick counts. The client can do that without us. If they're at home, if they get sent home, they can, every time they feel something, they can write it down and keep up with it. They need to adhere to appropriate diet, including standard diabetic diet and restricted carb intake. Dietary counseling by a registered dietitian should occur. So before they leave, we're not just going to hand them a pamphlet and be like, hey, eat better. We need to talk to them and let them know, you eat too many carbs, you're going to jack this up. You are going to have to follow this diet if you don't want to, keep this when you're done with it. Because a lot of times it will turn into that if you don't. You need to exercise. Perform self-administration of insulin. If they're having to take insulin, we usually want to have them do that in front of us so that we know that they know what they're doing. And then you document that, of course. So understanding the need for postpartum lab testing to include oral glucose testing and blood glucose levels. So obviously we know with gestational diabetes, we're going to check their sugar. Okay. All right, so now we're going to go to gestational hypertension. This is literally just hypertension while you're pregnant. So hypertensive disease in pregnancy is divided into clinical subsets of the disease based on in-organ effects and progresses along continuum from mild gestational hypertension, mild and severe preeclampsia, eclampsia, and hemolysis, elevated liver enzymes, and low platelet syndrome. So we're going to break that down. Your vasospasm contributing to poor tissue perfusion is the underlying mechanism for the manifestations of pregnancy hypertensive disorders. So vasospasms and poor tissue perfusion is the main cause for this. So gestational hypertension disease and chronic hypertension can occur simultaneously. You can have both. Like you can already have had the issue and then you can have this too when you're pregnant. Gestational hypertension or hypertensive diseases are associated with placental abruption, kidney failure, hepatic rupture, preterm birth, and fetal and maternal death. So anytime I think of hypertension, I think worry for your organs because we think hypertension, just our heart, is stressing our heart out. But you got to think about how vascular your kidneys are and your liver and how much you got going on in there. And if there's like too much pressure, that's going to destroy your liver. It's going to destroy your kidneys. You're going to have a lot more issues than just your heart and high blood pressure. And then throw into the mix that you're pregnant, and now it's messing with you and it's messing with your baby. So gestational hypertension usually begins after the 20th week of pregnancy, and we know that 20 weeks is viability, meaning your baby could survive outside of you by itself, meaning, premature. It describes hypertensive disorders of pregnancy where the client has an elevated blood pressure at 140/90 or greater. And this has to be recorded on two different occasions. Like you might just have a high blood pressure one day at 140/90, but if this has happened on two different occasions, at least 4 hours apart, and there is no proteinuria present. So if we know that if there's protein in our urine, what did we just go over? If we see protein in our urine, we are going to assume gestational diabetes. So they want to make sure that they're ruling other things out first. So 140/90, more than at least two occasions, and at least 4 hours apart. So your blood pressure returns to baseline by 12 weeks after you've had the baby, postpartum. So if your blood pressure returns to baseline by 12 weeks, we know that this was just gestational hypertension. It's not something that's going to stick around. So then we have preeclampsia, severe preeclampsia, and eclampsia. So preeclampsia, think proteinuria. You're going to have greater than or equal to 1%. So it's literally like it's in stages, basically. So it means before. Preeclampsia would be gestational hypertension. You're going to have the addition of proteinuria greater than 1 or equal to. You're going to have transient headaches and episodes of irritability. It says edema can be present. This is not like a telltale sign for this anymore. They used to not solely go by it, but they used to heavily ride on that, and it's not really a sign of it as much anymore. So proteinuria of 1+, transient headaches, and irritability. I would just stick with that. I usually try to go through. I'll let y'all peek at my hot mess over here, but I will go through and I'll highlight the most important words that I can find. I try not to do I'll cut out these and everything else and hit the highlights, and then I will go through and I will write what I just read beside it. So if I'm reading about dyspnea, I'm going to write difficulty breathing out to the side, or if I see hypotension, I'm going to put like a down BP, just because it helps to write it, to remember it. So if you're writing in your book, beside it, beside preeclampsia, proteinuria, 1+, transient headaches, irritability. And then for your severe preeclampsia, so this is just preeclampsia amped up. Your blood pressure is going to be 160/110 or greater. Proteinuria is greater than 3+. You're going to have an elevated blood creatinine greater than 1.1. Cerebral or visceral disturbances, because you got to think there's a lot of pressure with this hypertension. I don't know if you've ever had high blood pressure before, and you just feel like your head is about to explode. Like you feel like a tube of toothpaste that somebody's just done squeezed up to your head, and you get those headaches and you feel like you're going to explode. So cerebral or visceral disturbances because of the inadequate perfusion. So hyperflexia with possible ankle clonus. If you have not looked up ankle clonus before, look it up. It's wild. You need to look up ankle clonus. It's pretty cool. Pulmonary or cardiac involvement, extensive peripheral edema, hepatic dysfunction, epigastric and right upper quadrant pain, and thrombocytopenia. So these are all going to be telltale signs of severe preeclampsia. Eclampsia is going to be severe preeclampsia manifestation, so everything in the one before, but with seizure activity or coma. So onset of seizure activity or coma, and I think it was Callie that said, it was either Callie or Sarah Grace that said eclampsia, they think of epilepsy, because when you have epileptic seizures, it starts with the E, eclampsia. That's how we put those two together. So eclampsia is usually preceded by a headache, severe epigastric pain, hyperreflexia, and hemoconcentration. So if they draw your blood, it's going to be really thick. And these are warning signs or warning manifestations of probable convulsions. So your HELP syndrome, I do know we need to know that, is a variant of gestational hypertension in which hematologic conditions coexist, meaning together, with severe preeclampsia involving hepatic dysfunction. Hepatic meaning your liver. All right, so hemolysis resulting in anemia and jaundice. So we're going to have we don't have enough blood, and the jaundice, like yellow look. So your ELs, your elevated liver enzymes, resulting in elevated alanine aminotransferase ALT or aspartate transaminase AST, epigastric pain, nausea, and vomiting. So for the elevated liver enzymes, I would really focus on the ALT, AST. She may or may not ask a question about it, but I do know, I think I saw in the study a minute ago, you need to at least know what they stand for. And they're so short, we should be able to memorize those paragraphs. So the low platelets is going to be your last part of HELP, and it's less than 100,000 millimeters per cubic deciliter, I believe is what that stands for, resulting in thrombocytopenia, abnormal bleeding and clotting time, bleeding gums, petechiae, and possibly disseminated intravascular coagulopathy. We're going to dumb this down. Pretty much, if you have low platelets, you are not clotting correctly. You don't want your patient to use a toothbrush that is very hard. You want them to brush their teeth softly. You don't want them shaving with a razor. Anything that's going to cause somebody to bleed really easily, especially if you have a patient that has diabetes. What do? We never clip their toenails. We are not messing with that. So you have the hemolysis, elevated liver enzymes, and low platelets. All right, so our data collection for this, your risk factors, the chances of you having gestational hypertension include If you are younger than 19 years old or older than 40 years old, if this is your first pregnancy, if you're extremely obese, if you've had multifetal gestation, chronic renal disease, chronic hypertension. Why? Because we said that our kidneys are very, very vascular. So if you've already come in with a pre-existing condition, your chances are going to be more likely. Chronic hypertension, if we've already come in with hypertension and now we have this baby and now it's just going to worsen. Familiar history of preeclampsia. So this can be something that is just kind of carried through. Diabetes mellitus, rheumatoid arthritis, and systemic lupus. So these are your risk factors for being able to have gestational hypertension. So your expected findings, if you come in and your patient has gestational hypertension, severe continuous headache. Why? Because pressure. When we think hypertension, we think pressure like right here. Nausea. Sometimes you've had a headache that is so bad it makes you want to throw up. Blurred vision, because when you have a headache, you just want to lay down. Sometimes you can't see straight. It's so bad. Flashes of lights or dots before the eyes. And sometimes they call this an aura. And aura is usually a sign before you have a seizure. So sometimes there's, people that have seizures like often. The last thing that they remember seeing was some kind of float around a light, something, and they call it an aura. And that's kind of this is about to happen. This is coming. So those are your expected findings. Your physical findings, when you have your patient for testing, you're going to see that they have hypertension, obviously. Proteinuria, we're testing for that. Periorbital, facial, hand, and abdominal edema. So swelling. Pitting edema of lower extremities, and I'm sure that you guys have gone over this, but pitting edema just means that if you put your finger down, if you press it, it's going to leave an indentation. Anything you think pitting edema? Just think it's staying. It's going to hang out for a while. Vomiting, oliguria, hyperreflexia, scotoma, which we looked up is a partial loss of vision. Epigastric pain, right upper quadrant pain, dyspnea, which is difficulty breathing, diminished breath sound, seizures, jaundice, which is going to be yellowing because why? Your liver's struggling because it's vascular and it's getting messed up because of hypertension. Manifestation and progression of hypertensive disease with indications of worsening liver involvement, kidney failure, worsening hypertension, cerebral involvement, and developing coagulopathy. So that whole last paragraph goes over to the HELP syndrome, the things that you're seeing. And this is of extreme continuance. So your lab findings are going to be elevated liver enzymes, which we said over here, your LDH and your AST, because you're swollen. Increased creatinine, your kidneys are not functioning. Increased plasma uric acid, thrombocytopenia, which is a low platelet count, which is where we come over here to our low platelets, less than 100,000. Hemoglobin decreased in HELP, increased in preeclampsia. And then you have hyperbilirubinemia, which is just more bilirubin. So your diagnostic procedures for this are going to be a dipstick testing of urine for proteinuria. So you're going to have your patient sit on a nun's cap, and you're going to come in and test it to see if there's protein in this, and that's going to be one of your signs for it. A 24-hour urine collection for protein and creatinine clearance. And this may or may not be a question, but when you do a 24-hour urine collection, you're going to throw out your first sample. You don't use that. Non-stress test, contraction stress test by a physical profile, and serial ultrasounds to monitor fetal status. And these are all pretty normal tests for any kind of thing during pregnancy. And we did go over that through 1 through 6 for sure. Doppler blood flow analysis to monitor fetal well-being. We're always going to check the fetus status first. Miss Shawn said that a bajillion times. We're going to put those straps on them, and we're going to check what's going on with the baby first. And then you're going to do your daily kit counts, which you can do if your patient is in the hospital or a facility with you, or they can do it when they're at home. So your patient-centered care is going to be monitor their level of consciousness. Why? Because if our patient does end up having eclampsia, they can slip into a coma. They can have a seizure. So, if you've left the room, you come back, you want to make sure that your patient is not, make sure they're sleeping and not in coma. You're going to want to obtain the pulse ox because we're having all kinds of issues with our blood here. We want to make sure that they are, their pulse ox is normal. Monitor urine output. If you're monitoring output, you're probably monitoring input. I just do INO every time. Daily weights, this is the most important because why? Your weight is the most accurate tell of your I's and O's. Monitor your vital signs and careful attention to blood pressure management. So you're going to make sure that you're using a proper cuff, because if we use the wrong cuff, it can be too high, it can be too low, it won't be accurate. Encourage lateral positioning. So we want to get them off of their back. Why? Because it's putting pressure on the superior vena cava, and that increases blood pressure. So we already have a high blood pressure. We don't want to add to that. We want to assist with obtaining NST and daily kick counts. Reinforce instructions to the client to monitor I and O. So if that means your patient is in a facility with you and they're not at home, you want to say, hey, if you need to go to the bathroom, call me. We're going to help get you up, and we need you to use this nun's cap. If they can get up by themselves, which we want to kind of be careful with, especially if they have, eclampsia and they may be having a seizure or a coma. We don't want them getting up and go to the bathroom by themselves. We want to help them, but they need to know to use that nun's cap every time, because you're trying to keep up with what they're taking in and putting out. For your medications, it's usually recommended that a daily dose of aspirin therapy be initiated late in the first trimester for clients who have a history of early onset preeclampsia. And we know that aspirin is a blood thinner. Antihypertensive medications, we have methyl-dopa, nifedipine, hydralazine, and labetalol. And a group of us memorize this as my niece has lice. And this is for antihypertensive medications. So with these, you're going to avoid ACE inhibitors and angiotensin II receptor blockers. I don't know how you can remember that, but just know that you do not take ACE inhibitors with these, and you're not going to take angiotensin II receptor blockers. So your anticonvulsant medication is going to be your mag sulfate. Mag sulfate she hit on all through these chapters, so I would definitely know this. It's the medication of choice for prophylaxis or treatment to depress the CNS and prevent seizures in a client who has eclampsia and severe preeclampsia. So if your patient has eclampsia or severe preeclampsia, you're going to give them mag sulfate to kind of keep this at bay. It's going to chill it out. So you're going to use an infusion control device to maintain a regular flow rate. You're going to probably have them hook up to IV, and it's going to be consistently when it's coming out. You're going to monitor blood pressure, pulse, respiratory rate, deep tendon reflexes, LOC, urinary output unless they have an indwelling urinary catheter, and then you can read the bag. Presence of headache, visual disturbances, epigastric pain, uterine contractions, and fetal heart rate always, and activity. Basically your vital signs and then some. You're going to monitor for manifestations of mag sulfate toxicity. So we need to know, what does mag sulfate toxicity looks like, and then we need to know how to fix it. She wants to know the antidote. We are going to have to know the antidote. So if you have absence of patellar deep tendon reflexes, urine output less than 30 milliliters an hour, which is we should all have 30 milliliters or more an hour of urine output. If you have less, that's a sign. Respirations less than 12, that's always a given. If you have less than 12, something needs to be done, unless your patient's on hospice and we're expecting that. Decreased level of consciousness, coma, seizure, we're watching for that. Cardiac dysrhythmias. So if mag sulfate toxicity is suspected, you are going to go let an RN know immediately. Immediately discontinue the infusion. We're going to kind of treat it like a blood transfusion. If they're starting to have an allergic reaction, you're going to cut that off first, then get somebody. Or if sometimes you have a buzzer on the wall next to your patient, you'll do them simultaneously. You're going to administer antidote calcium gluconate or calcium chloride. It's the only antidote, I think, in these chapters, so it should not be hard to memorize that. You're going to assist with preparing for actions to prevent respiratory or cardiac arrest, meaning if your patient has preeclampsia, severe preeclampsia, eclampsia, you probably maybe should sort of kind of have a crash cart there. Because if your patient starts to slip into a coma or is having a seizure, you want to be able to have stuff next to you to be prepared to handle it. And you also need to know what to do if your patient is having a seizure to protect them and protect people around them. You want to make sure they're not near something that they can hurt themselves on. And never stick your finger in somebody's mouth. That's like a super old thing where you put a spoon in the back of somebody's mouth or your finger. Never put anything in their mouth. Just keep them safe. Assist with preparing for the actions for respiratory or cardiac arrest. So you need to be able to have something available to stop this. There can be initial feelings of flush, heat, sedation, diaphoresis, which is sweating, and burning at the IV site with mag sulfate bolus. These are normal feelings when you have this, because a bolus is a fast. You're intaking something really, really quick, which, by the way, We never do. We don't deal with boluses. We don't do that. That's RN. But they may feel like that flushing heat. I don't know if you've ever been to the hospital and you've had morphine or something, before a procedure. It kind of makes you feel hot. You kind of feel flushed. That's what this feeling is like. So you're going to want to educate your client, let them know that could be a feeling that they're going to have, and that's normal. Remain on bed rest and on the sideline position. Why? We don't want them up doing a bunch of crazy stuff if their blood pressure is already high, and we want them to be in a sideline position so they're getting the pressure off of the superior vena cava. We want to perform diversional activities, provide a diversion, a distraction, TV, visits from family or friends, which we probably wouldn't do right now, and gentle exercise. Avoid foods that are high in sodium. Why? Because sodium causes hypertension. Avoid alcohol and tobacco and limit caffeine intake. Why? Because it causes hypertension. Drink 6 to 8 ounce glasses of water per day, which we should probably all be doing, and we're probably not. Maintain a dark, quiet environment to avoid stimuli that can precipitate a seizure. So if I'm known to have epileptic seizures, or I have this eclampsia, you're going to want to turn the lights down. You're not going to have strobe lights going and a whole bunch of music and the TV roaring and stuff. You're going to want to have it kind of chilled out so that you pull yourself out of this situation. You don't want to cause that. Maintain a patent airway in the event of a seizure. Crash cart. You need to be prepared to take care of that suctioning equipment, all that good stuff. Take antihypertensive medication as prescribed. So we don't want our patient to be taking stuff willy-nilly. They need to know when they should be taking something, how often they should be taking something, and a lot of the times if they're with you at the facility, you'll be the one to administer it. But in the case that they go home, we need to make sure that we have educated our patient and documented it. All right, so that is the end of chapter 8. Do you guys want to take a break and come back and do 9, or keep going? All right, I'm going to give it like 2-3 more minutes, and then we'll go with 9. And 9's really short. Do you guys have any questions so far? All right, I'm gonna keep going through. We're gonna start on 9, and it's literally like 2.5 pages long. There's also a breakdown of chapter 8 on the website. I didn't get a chance to do 9, 10, 11, much less 11, 12, 13. But I like to try and do like one thing on one piece of paper because it's easier to break that down for me, but there's just not enough time with all the stuff we have in the short amount of time that we have it. But there's a breakdown for 8 on the website. All right, so chapter 9 is early onset of labor. All right, so understanding the importance of identifying early onset labor includes preterm, premature, and preterm premature rupture of membranes. All right, so preterm labor is it's going to be uterine contractions and cervical changes that occur between 20 and 36 weeks and 6 days of gestation. If it would have been one more day, it would have just been 20 and 37 weeks. So preterm labor can be categorized as very preterm, which is less than 32 weeks of gestation, moderate, which is 32 to 34 weeks, and then late, which is 34 to 36. It just goes in twos. So 32, 32, 34, 34, 36. Shorter gestation is associated with increased neonatal risk. So the less that they're in there baking, the more chances that they're going to have issues. So the risk factors for preterm labor are going to be infections of the urinary tract, so UTI or vagina, HIV, active herpes infection, or chorioamnionitis. And this is just an infection of the amniotic sac. Previous preterm birth, so if you've had this before, multifetal pregnancy is, I don't know if we've caught on to this or not, but it's pretty dangerous to have more than one. Like the more babies you have in there at one time, the more dangerous it becomes. Oligohydramnios, which we said was too much fluid. I'm sorry, too little fluid, and then the hydramnios is too much. Advanced maternal age, if you're older, you might have more issues with preterm labor. If you're a smoker, using drugs, drinking, if you've been abused, so violence or abuse, history of multiple miscarriages or abortions, because it's damaging your inside, is damaging the uterus the more that this happens. Diabetes mellitus, chronic hypertension, preeclampsia, lack of prenatal care. A lot of us don't have access to that. And that can also cause preterm labor because we're not keeping up with our stuff. It might have been something that we could have caught before. Placenta previa or abrupto placenta. So placenta previa, to back up, is when your placenta has moved down. It's usually like in the top-ish area. It's moved down and it's now blocking the cervix. So baby's gonna have a hard time coming out if there's no entryway. And then abrupto placenta is when it detaches from the mother really, really soon. We can't do that because how's your baby getting this stuff? Preterm premature rupture of membrane, so early water break. Second trimester bleeding. Remember, she said no blood is good. We don't need any kind of stuff like that. Low pregnancy weight. So if you are not gaining the weight that you're supposed to, maybe you're already thin and it's hard for you to gain the weight. Some people just don't. That could also cause you to go into preterm labor because your baby's not getting what they need. Lack of access to prenatal care. I was about to say that one's on there twice. There's lack of prenatal care, meaning like we just didn't care, didn't want to do it, and then lack of access to prenatal care because we didn't have a way to get it. Congenital fetal anomalies, meaning the baby already has issues. So that could also cause this to happen. So your expecting findings when you see somebody in preterm labor is going to be uterine contractions. Obviously, they're having this baby too early. Pressure in the pelvis and menstrual-like cramping. We hate those. Persistent low backache, GI cramping, sometimes with diarrhea, urinary frequency, and vaginal discharge. Your physical findings are going to be increased change, odor, or blood in vaginal discharge, changes in cervical dilation, regular uterine contractions with a frequency of every 10 minutes or greater, lasting more than 1 hour. So you can have premature rupture of membranes, which is like your telltale, I'm going to labor, we're about to have this baby. And then a discomfort or dull lower abdominal pain or back pain, pelvic pressure or heaviness. So like you're going to know something's not right. This ain't like a menstrual kind of pain. This is like is happening. So your lab tests are going to be the FFN, and so a positive is not good. A good person to ask about this would be Sarah Grace or Callie. They did really good at explaining it, but there's a video I can try to send to the group later. And this is basically where when the placenta and the mother's uterus are together, there is it's almost like HCG. Like you're going to see a change in this fetal fibronectin. When you think fibronectin, it literally looks like fibers connecting the uterus and the placenta together. Well, if this is positive, that means you're going into labor. So it should only be like when it's first binding together and when it's coming apart. You should not see it during normal pregnancy time when you're not in labor. So I'll try to find that video. It explains it more in depth. We might not have to know it that in depth, but sometimes it helps to make that connection for me. So cervical cultures, because we want to know if there's infection in the vagina, HIV, herpes infection, that kind of stuff. We want to do cervical cultures for that stuff. CBC and UA. So your diagnostic procedures is the FFN. Swabs of vaginal secretions are collected to determine the presence of FFN. This protein can be expected during early and late pregnancy, but presence between 24 and 34 weeks and 6 days can indicate inflammation, which increases risk for preterm labor within the next 2 weeks. So FFN testing combined with cervical measurements is the best way to determine risk for preterm labor. I would know that if it says it's the best way to do this, it's the best indicator, best test, I would probably know that. I don't know if it's on her study guide or not, but it's worth looking into. So early on and later, but between 24 and 34 and 6 days, it should be a no-go because that means you're inflamed. All right, so we're obviously going to use the ultrasound to determine the measurement of endocervical length. Cervical shortening occurs before uterine activity, contractions. So this can be a predicator of risk in conjunction with other findings. Cervical length greater than 30 millimeters indicates low risk for preterm labor. So I know it said 25 in another place, in the last chapter, but I would know what the shortening and lengthening means. So your cervical cultures to check for presence of infectious organisms. Culture and sensitivities results guide prescription of an appropriate antibiotic if indicated. And then again, your biophysical profile or non-stress test to provide information about fetal well-being. So for your patient-centered care, what you're going to do, your main thing is going to be to stop the contraction. It's too early. We don't want this. What are we going to do to stop it? Well, you're going to have activity restriction. Why? Because gravity works. We want them to chill out. So modified bed rest with bathroom privileges is like the main thing that we've been seeing. Encourage client to engage in activities that can be completed in bed or on the couch, maybe like a puzzle, watching something on the tablet, things like that. Strict bed rest can have adverse effects. So if you keep them in the bed for too long and they're not getting up to go to the bathroom and stuff, what do you normally see when somebody's laying down for too long? Skin breakdown. Or they're going to stay and they're going to lay on their back and then they're going to have issues because they're laying on suppressing vena cava. So we don't want them laying for too long in one spot. And we don't want them laying for too long. You're going to encourage the client to rest in the left lateral position to increase blood flow to uterus and decrease uterine activity. And tell the client to avoid sexual intercourse. No sex. No, none of it at all. Next, hydrate. Because why? Dehydration leads to contractions, and we're trying to stop those. Identifying and treating an infection. So if they have vaginal discharge, you need to note the amount, color, consistency, and odor because this can tell us what's going on. Temperature. That's also indicative of an infection. Chorioamnionitis, which is the infection of the amniotic sac. We need to test for that as well. So we're going to monitor fetal heart rate and contraction pattern. Always fetal heart rate. Fetal tachycardia, which is prolonged and increased greater than 160 a minute, can indicate infection. So when we have tachycardia, it's usually an indicative of an infection. So our baby's probably going to have one too. So normal is 110 to 160, and tachy means infection. All right, so here come the medications. And I think it was Callie or Sarah Grace that told me this. I'm trying to give credit where it's due. I don't know if they heard it somewhere else where it came from. Maybe the teacher said it. I don't know. But for your medications, think it's not my time. And then I added it's not my time, baby, at the end because there's another medication over here that starts with a B. But in this class of contraction stoppers is what I'm calling them, is it's not my time. So we'll go straight down the line instead of going in that order. But for the medications, you have nifedipine, and this suppresses contractions. So it's a calcium channel blocker and inhibits calcium from entering smooth muscles. I don't think she's going to want to know all that because this isn't pharm. You probably will need to know that when you do pharm. But you're going to monitor for a headache, flushing, dizziness, and nausea. These are usually related to orthostatic hypertension that occurs with administration. So we know that orthostatic hypertension, it took me literally a whole semester before I actually looked up what that meant, and I probably should have done it sooner. But that is basically when your heart rate, your blood pressure, all those things are getting jacked with when you move. So if you get up too fast or you roll over too soon or something, like it'll make you dizzy. It'll make you not feel good. So we want to watch for that. We want to make sure that it's not administered concurrently with mag sulfate or immediately following a beta-2 adrenergic agonist, which is, hold on, I just looked at this and now I need to look back at it again before I tell you a lie. No, that's different. Okay, so don't give nifedipine with mag sulfate or after beta-2 adrenergic agonist. I'm going to highlight that in my book because I didn't. All right, so for your client education, when they take this medication, slowly change positions from supine to upright and sit until dizziness disappears. So with the orthostatic hypertension, we want to let them know, be careful, don't be getting up and trying to do crazy stuff. You're going to fall out. Maintain adequate hydration to counter hypotension. So if we have a low blood pressure, that means there's not enough in there. We give fluids, and that's going to bring us back up and fill that space. All right, mag sulfate, her favorite. This is commonly used as a tocolytic and is a central nervous system depressant that relaxes smooth muscles and inhibits uterine activity by suppressing contractions. So fancy, you need to know tocolytic and stops contractions. Contraindications for this, meaning you don't need to use it, is during active vaginal bleeding, dilation of cervix greater than 6 centimeters, because at that point this baby's coming on. We ain't trying to stop the contraction, it is happening. Chorioamnionitis greater than 34 weeks of gestation, and acute fetal distress, because if it's acute fetal distress, we're not going to try to stop the contraction. We're trying to get this baby out. Do not use concurrently with nifedipine, and don't give to clients who have myasthenia gravis. Don't know if that's going to be some kind of question or not. It's kind of I would say that's a zebra for me because it's not often that we see the myasthenia gravis. Let's see. Okay, you're going to monitor closely, discontinue immediately if they have manifestations of pulmonary edema, which includes chest pains, SOB, respiratory distress, audible wheezing and crackles, and productive cough containing blood-tinged sputum. So a question she might have would be, patient is, let's see, like 32 weeks pregnant and is taking mag sulfate. Patient complains of shortness of breath, and upon auscultation, you hear crackles, and patient has a productive cough with blood-tinged sputum. What is your next move? Like, what do you do next? What's your nursing action? You're going to stop that immediately. You're going to discontinue because you should not be hearing a fluid buildup, which is where you have your wheezing and crackles. Most of the time, if you see a question that has to do with pulmonary edema, the answer is going to be wheezing or crackles. So you're going to monitor for adverse effects, hot flashes, diaphoresis, which is sweating, Burning at IV site, nausea, vomiting, drowsiness, blurred vision, headache, non-reactive non-stress test, and reduced fetal heart rate variability. You're also going to monitor for mag sulfate toxicity, which we talked about in the last chapter. You need to know the signs of that, and you need to know the I completely lost the word. Antidote. All right. So, if you see manifestations of magnesium sulfate toxicity, you want to discontinue immediately. And we know that if there's a urinary output less than 30 milliliters, respirations less than 12, pulmonary edema, severe hypotension, or chest pain. And then what is our antidote for mag sulfate? I'm gonna let you guys type it in there. What is the antidote for mag sulfate? Yes. All right. Calcium gluconate or calcium chloride. All right. So we're going to notify the nurse if the patient has blurred vision, headache, nausea, vomiting, or difficulty breathing. All right. And then we're going to go to terbutaline. And this is a beta adrenergic agonist that's used as a tocolytic and relaxes smooth muscle and inhibits uterine activity. This is so extra. It literally stops contractions. Collect data for history of cardiac disease, pre-gestational or gestational diabetes, preeclampsia with severe features of eclampsia, severe gestational hypertension, hyperthyroidism, or significant hemorrhage. If the client has any of these, the medication should not be administered. So literally half the stuff that we just went over in the last chapter, you don't give terbutaline to them. Monitor for chest discomfort, palpitations, dysrhythmia, tachycardia, tremors, nervousness, vomiting, hypokalemia, hyperglycemia, or hypotension. Notify RN if heart rate is greater than 130 per minute, chest pain, cardiac arrhythmias, myocardial infarction, blood pressure less than 90/60, or pulmonary edema. And somebody tell me what is one sign of pulmonary edema that you might see on a question. And it's usually the choice. One prevalent sign of pulmonary edema. Oh. They're fine. Yeah, the washing machine was going crazy earlier. Nobody knows. All right, so one sign of pulmonary edema that's usually going to be the choice is if you hear crackles or wheezing. That means there's a fluid overload in your lungs. So if you have that, you're going to discontinue the terbutaline. All right, so all right, you're going to administer 0.25 milligrams sub-Q, which means under the skin, every 4 hours for up to 24 hours. And discontinue if the client cannot tolerate adverse effects. So chances are they're going to have the adverse effects. It's just whether or not it's outweighs the bad for the patient. All right, then you have indomethacin. This is an NSAID that suppresses preterm labor by blocking production of prostaglandins. So we know prostaglandins, cause contractions. So this is going to block those and suppress uterine contractions. So all of these 4 medications are going to stop contractions because it's too soon. This medication can cause premature narrowing or closure of the ductus arteriosus in the fetus. Nursing actions, you're going to monitor your client closely. Discontinue the tocolytic therapy if they have pulmonary edema, if they have chest pain, SOB, respiratory distress, audible wheezing and crackles, or productive cough containing blood-tinged sputum. So a lot of these have the same side effects, and you're going to discontinue because that is an adverse effect and a side effect are different. A side effect is going to be something that you're most likely going to have, like, I don't know, you're going to have blood thinning when you take aspirin, but an adverse effect will be something way serious way more serious than that, something that you're not totally expected to get, and some people have like a weird thing about it. All right, so indomethacin treatment should not exceed 48 hours. So we're not going to give it to them more than 48 hours. And it should only be used if gestational age is less than 32 weeks of gestation. So if they're less than 32 weeks, we use it, and no more than 48 hours. We're going to give it with food or rectally to decrease GI distress. So this is not going to sit well with you. So we're going to either give it with food so that it kind of chills it out a little bit, or rectally because it bypasses all that stuff. Immediately, I did notify the RN if the client reports blurred vision, headache, nausea, vomiting, ringing in the ears, or difficulty breathing. So everything in this notify the RN is exactly the same except for one thing, and that is going to be your zebra. So immediately notify RN if client reports blurred vision, headache, nausea, vomiting, ringing in the ears, or difficulty breathing. What's the one thing that's different in there than all the other medications that's telling you to notify about? We've kept saying blurred vision, headache, nausea, vomiting, difficulty breathing, dyspnea, SOB, but we haven't heard ringing in the ears yet. So indomethacin, we're looking for something. We're looking for the zebra. We're looking for what's different. So we're going to monitor the neonate at birth, and that is the end of the. Going back, medications to stop contractions. You just have those 4. So the last thing that you're going to have, and this one she hit on really, really hard, was the betamethasone. And we need to know this one. This is a glucocorticoid that requires 24 hours to be effective. So it's not going to kick in as soon as we give it. It's going to take about 24 hours. And this is to enhance fetal lung maturity and surfactant production in fetuses between 24 and 34 weeks. So if we back all the way up to the very, very beginning of Miss McGee's class, we know that surfactant production is keeping the alveoli in your lungs open. So when you see your lungs, the very, very bottom where it branches out, you have your alveoli, and they look like grapes, but they're like microscopic, teeny tiny. Those have to be filled with something. They can't be empty. They can't collapse. So those have surfactant in it. So this betamethasone is going to help you breathe better, is how I remember it. So a fetus between 24 and 34 weeks of gestation, it's going to enhance fetal lung maturity. So it's going to up their chances of having better lungs, because a number one thing in premature infants is that their lungs didn't develop properly, and that leads to a handful of other issues. So betamethasone is better breathing for the baby, and this has to do with surfactant in the lungs. So you're going to give this 12 milligrams IM in 2 doses 24 hours apart. You're going to administer deep IM using ventral, gluteal, or vastus lateralis muscle at least 24 hours, but no more than 7 days prior to delivery. And you're going to monitor for maternal hyperglycemia, because this can affect that. You're going to report any findings of pulmonary edema, chest pain, SOB, and crackles. That's been one for every single medication in here. So betamethasone. And then it actually is over here again for premature rupture of membranes or preterm premature rupture of membranes. So we are now on the last part of chapter 9, and this is premature rupture of membranes and preterm premature rupture of membranes. So PROM is spontaneous rupture of amniotic membranes prior to the onset of true labor, so early water breaking. And for most clients, it signifies the onset of true labor of gestational duration is that term. So normally when your water breaks, it's because it was supposed to. It's because you made it that far, and that's where you're supposed to be at. But PROM is just too soon. All right, so preterm premature rupture of membranes is the premature spontaneous rupture of membranes after 20 weeks of gestation and prior to 37 weeks of gestation. So between 20 and 37 weeks is when you have your PPROM. So your data collection, your risk factors for having one of these 2 would be if you've had an infection, if you've had a prior preterm birth, shortening of the cervix, 2nd or 3rd trimester bleeding. Why? Because we don't want any bleeding. No bleeding is good. Pulmonary or connective tissue disorders, low BMI, which is your body mass index, copper or ascorbic acid deficiencies, or tobacco or substance abuse. We know you don't smoke when you're pregnant, and you should not drink when you're pregnant because it affects the baby. So your expected findings are going to be a gush or leakage of clear fluid. This is what we know is our water breaking, like the telltale sign. Monitor for prolapsed umbilical cord, abrupt fetal heart rate variable, or prolonged deceleration. She said that word a lot. Visible or palpable cord at the introitus. Remember when we went through our stages in the lab and I was helping Bailey give birth and we were joking around about her umbilical cord hanging out? This would be a prolapsed umbilical cord, and you don't want that. So your lab tests are going to be a positive nitrazine paper test, and she did go over this quite a bit. We said it in lab as well. If you have the P test and you take this on this nitrazine paper, if it's blue, it's amniotic fluid, and if it's yellow, it's P. It's super easy to remember. And the P, if it is blue and it is amniotic fluid, it should be between 6.5 to 7.5 pH. So we're more on the acidic side. You want to verify the rupture. So your patient-centered care, you are going to assist the RN in preparing for birth if it's time. You're going to obtain vaginal rectal cultures for strep because it's funky down there. You got a lot of stuff going on. You're going to do cultures and make sure that there is no streptococcus beta hemolytic because you giving that stuff to the baby. Obtain vaginal cultures for chlamydia and Neisseria gonorrhea. We want to make sure that they don't have anything like this before having the baby. Limit vaginal exams because you're not going to want to be poking around in there if you've already got stuff going on, especially if you do have a prolapsed umbilical cord. You're not pushing around nothing and you sure are not yanking anything. Provide reassurance to reduce anxiety because that's probably really scary. Check vital signs every 2 hours and if they have a temperature greater than 100.4. Monitor fetal heart rate and uterine contractions, always. Hydrate. Obtain a CBC. Anticipate prescription for a 7-day course of broad-spectrum antibiotics. And going back to Miss McGee's lecture, broad-spectrum antibiotic is what the antibiotic you give before you know exactly which antibiotic you need. So if you don't know if it's strep yet, you just give like a baseline antibiotic to kind of start working on that before you figure out what the real issue is. So the medications for this are going to be ampicillin, which is in the penicillin family, and this is to treat the chorioamniotitis, which is the infection of the amniotic fluid. So you are going to obtain vaginal urine and blood cultures prior to administration of the antibiotic, and you're going to get a culture on all the fluids. You want to make sure everything is looking the way it's supposed to. Then you have betamethasone again. And this we know is the glucocorticoid to enhance fetal lung maturity and surfactant production. Betamethasone, better breathing for the baby. This dog's having a nightmare. All right, so we know single dose is given with PROM. I made a chart in my book to break it down because it was kind of confusing over here. But for PROM, it's going to be between 24 and 34 weeks. Lower risk of mortality, respiratory distress syndrome, and distress syndrome. For PPROM, 24 to 34 weeks and a lower risk of distress syndrome. So your complications because of this can be infection, particularly chorioamniotitis. It is the most common complication of PPROM. Why? Because if you have an infection in that amniotic fluid, your baby's taking that in, and that needs to be taken care of quickly. So other complications would be placental abruption, which is your placenta detaching from the uterus, umbilical cord compression or prolapse, so something's pushing down on it, squeezing it, or it's coming out, fetal pulmonary hypoplasia, and death. So if you're going to want to teach your client, depending on gestational age, hospitalization can prolong pregnancy while monitoring for risk factors. So they may have to stay in for a while because we want to monitor them and watch. You're going to adhere to limited activity with bathroom privileges, hydrate, self-assessment for uterine contractions, record daily kick counts, monitor for foul-smelling discharge, abstain from intercourse, avoid tub baths. Why? Because if you're sitting in a tub of water and your water breaks, how do we know if it was pee? How do we know if it was amniotic fluid? We don't know because we can't test it because you were in the tub. So we don't do baths. White perineal area front to back, which we should all be doing from the day that we're potty trained, and some of us still don't. Because we don't want to take bacteria up to the front because then we're seeing that and it's being passed on. Take temperature every 4 hours when awake and report a temperature greater than 100. So that is all for 9. Do you guys want to take a break before we go into the last one, or you want to keep going? 10's kind of long. It's not that bad, though. Y'all want to keep going and do 10, or y'all want to take like a 2 or 3 minute break? No, but you can come in here. You're fine. It's the best. I need to clean that up. All right, any questions so far? You guys good to keep going to the last one? All right, well, I'm going to keep pushing through 10 then. I think we started out with 9. We're down to like 7. It's getting late. All right, so chapter 10 is nursing care of the client in labor. So we're reaching the end of this. All right, so the intrapartum nurse should assist with the care for 3 clients during labor and delivery: the fetus, mother, and the family unit. So your physiological changes preceding labor or premonitory signs are going to be backache, which is a constant low, dull backache caused by pelvic muscle relaxation; weight loss, actual weight loss of 1 to 3.5 pounds; lightening, which is fetal head descends into true pelvis about 14 days before labor; feeling that the fetus has dropped and you have easier breathing. So I literally just wrote in here, lightening, easier to breathe, and I think that's what she said in class too. So just know it's lighter, your lungs feel lighter, it's easier for you to breathe. All right, contractions begin with irregular uterine contractions, and these are your Braxton Hicks that eventually progress in strength and regularity. So sometimes people will come in thinking they're about to have this baby, and it's just Braxton Hicks. You have increased vaginal discharge, or a bloody show is what she called it; expulsion of cervical mucus plug, brownish or blood-tinged mucus plug resulting from the onset of cervical dilation and effacement. And remember, we said that dilation is the opening of the uterus, and then effacement is going to be the thinning. So open, dilation, thinning, effacement. Energy burst, sometimes called nesting in response. So when kind of wait until the last minute to put that crib together and get the room together because we're rushing, and it's just like a burst of energy. Why? Because they can breathe better because of this lightning. GI changes, so it's less common, but it would be like nausea, vomiting, and indigestion. Cervical ripening, meaning that it becomes soft, it starts to open, partially effaced, so partially thinned, and begins to dilate. So she gave us this sheet, and I think, Casey put it in the group, and this is the one that she gave us to go with instead of the stages of labor on page 69. So this is going through stage 1, 2, and 3, and 4 of labor. So stage 1 is your dilation, 0 to 10 centimeters. I'm looking off this sheet now, and it has 3 phases. You have the first phase, which is latent; the second phase, which is active; and phase 3, which is transitional. So your latent phase, your contractions are going to be 5 to 20 minutes, lasting 30 to 50 seconds, and you're dilated 0 to 4. Active phase 2 is 2 to 4 minutes, lasting 45 to 60 seconds, 4 to 8 dilated. Phase 3 is your transitional, and that's 2 to 3 minutes, lasting 60 to 90 seconds, 8 to 10. So if you're looking at these contractions, it's going to have longer minutes and shorter seconds, and then it's going to have shorter minutes and longer seconds. So if for some reason we have to match that up, that's a good way to remember. And we always know that when we're dilating, we're going from 0 to 10. 10 is you're out. Stage 2 is birth or expulsion. So this begins with complete cervical effacement, meaning it's thinned out, and dilation, opened up, and ends with the birth of a baby. So baby positions go through the cardinal movements. Cephalic presentation, most common. That's your head. Engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. And I am going to go back to the book for this part because it goes more in depth. So we have rupture of membranes. This is spontaneous rupture of membranes that initiate labor or can occur anytime during labor, most commonly during the transition phase, which is phase 3 of stage 1. Prolonged rupture of membranes greater than 24 hours before delivery of fetus can lead to infection. So if this is your water broke a day ago and you still haven't come into the emergency room to have this baby, it needs to be within 24 hours that you go in and start having this done. So immediately following rupture, you should check fetal heart rate as usual. Abrupt decelerations, which are indicative of fetal distress, to rule out umbilical cord prolapse. So we are making sure that this baby's still getting everything that it needs while we're trying to get this baby out. So you're going to evaluate amniotic fluid completed once the membranes rupture. So amniotic fluid should be watery, clear, and have a yellow tinge. Slightly yellow tinge. Odor should not be foul. Volume between 700 and 1,000 milliliters. So when you think of your water breaking, think of hanging normal saline bag. It's usually 1,000 milliliters. So use nitrazine paper to confirm the amniotic fluid as is present. Love you. Good night. So the nitrazine paper for color, we know if it's blue, it is amniotic fluid. We know that if it's yellow, it is pee. Urine is slightly acidic, so nitrazine paper remains yellow. And then we have our 5 Ps, which I do know that she put on that sheet because I saw it just a minute ago. You have passenger first, which is your fetus and placenta. So this consists of fetus and placenta, size of the fetal head, fetal position, fetal lie, fetal attitude, fetal, sorry, I lost my place. Position affect the ability of the fetus to navigate through the birth canal. The placenta could also be considered a passenger because it also has to pass through. So your presentation is how it's lying and coming out. The part of the fetus that's entering the pelvic inlet first, so what's coming out of the bottom first, and leads through the birth canal during labor. It can be the back of the head, which is occiput, which we think of our occipital lobe is at the back of our head. Your chin, which is your mentum, and I usually think of like men have a more defined chin. Shoulder is your scapula, and breech, which is sacrum or feet, so butt or feet first. And then your lie is going to be the relationship of the maternal longitudinal axis, or your mom's spine, and the fetal longitudinal axis. So if this is mom's spine, you want baby's spine to be like this as well. So if it's like this is transverse. So when I think of transverse, I think of a Chevy Traverse. It's a vehicle, and you have to drive like this. So transverse. If your baby's laying like this, mama's like this, it ain't gonna happen. Parallel or longitudinal, we want them to be straight with the mom, but we do not want them to be breech. So if they are straight up and down, we want the cephalic first, or occiput, sorry. Let's see. Do look over the findings in the first stage for the blood pressure. I think she did go over that for latent, active, and transition phase. I think that might be on that sheet, actually. Okay, then we have attitude, relationship of fetal body parts to one another. So fetal flexion is chin flex to chest, extremities flex to torso. So when you think flex, this area is getting smaller. So when I flex, it's smaller. When you think of a baby coming out, this is a baby, they can come out like this. So once they come out, their attitude, if they can be flexed, a fetal flexion, or that can be fetal extension. So I can flex this, I can extend it. So fetal extension, everything, or fetal flexion, everything's curled up. Fetal extension, everything is relaxed out away from the chest. So this is really just being able to break down words for the most part. Fetopelvic or fetal position. So the relationship of the presenting fart, I said fart. Relationship of the presenting part of the fetus in position with the opening of the vagina, basically. So is it going to be sacrum? Is it going to be mentum? Is it going to be occiput? Preferably occiput, so we want head first, in reference to its directional position as it relates to one of the 4 maternal pelvic quadrants. So quadrants. I don't think that she's going to go too crazy over this, but I would look at it. So the first letter references the side of the maternal pelvis, mom's pelvis, left or right. Occiput, sacrum, mentum, or scapula. So is it head first, butt first, foot first, chin first, or shoulder first? Mom's position, what part's coming out first is the second half. And then you have anterior, posterior, or transverse. The third letter references the part of the maternal pelvis. All right. The station is measurement of fetal descent in centimeters, with station 0 being at the level of an imaginary line level of the ischial spines, minus stations superior to ischial spines, and plus stations inferior to ischial spines. This is super extra. Don't know why they do that. Okay, so this was where she was talking about the where the baby's coming out. Your pelvis is right here where my thumbs are. 0 is your pelvis. Then you're going to have -1, -2, -3, -4, up. Below your uterus, the outside of your body, would be 1, 2, 3, 4, and so on. So 0 is the pelvis, negative is above, and positive is going to be below. So this is how we're measuring. We can say ROA. So the mom's right side, head first, anterior, and we're at a -1. So we haven't made it to that yet. This is just how they're gauging the stages. So station is going to be measurement of fetal descent we just went through that. Sorry, that's the -1, 0, positive ones. So your passageway is your birth canal. So it's composed of bony pelvis, cervix, pelvic floor, vagina, introitus, which is your vaginal opening. Size and shape of bony pelvis must be adequate to allow the fetus to pass through it, and the cervix must dilate and efface in response to contractions and fetal descent. So your powers are going to be dilation and effacement, which we know dilation is the widening and effacement is going to be the thinning. I don't even know if I will go through all that. Occurs once labor has begun and the fetus is descending. Involuntary urge to push and voluntary bearing down is the second stage of labor, helps with expulsion of the fetus. So we know it's time to push. Position, move positions, and gravity works is what I wrote when I was taking notes. So gravity can aid in fetal descent in upright, sitting, kneeling, and squatting positions. So we are moving positions a lot. We're kind of leaning on like one hip, moving to the other hip. We're going to put like a wedge between us. We're going to get up. We're going to bounce. We're going to move. Your psychological response is, how is the mom taking this? How is she dealing with it? So maternal stress, tension, anxiety can produce psychological changes and impair progression of labor. So if mom's stressed out, the whole thing's going to be a loop, which we get into later. So your pre-procedure, before you go in to do this, you have your Leopold maneuvers, which is abdominal palpation of fetal presenting part, lie, attitude, descent, and probable location where fetal heart tones can be auscultated in the client's abdomen. So this is Leopold, would be kind of an overview of the 5 Ps a little bit, I feel. And auscultating means you're going to be listening for the fetal heart tone. So where on mom's belly can you hear it the best? Then you have the toco transducer, which is the external electronic monitoring. So separate transducer applied to maternal abdomen over fundus that measures uterine activity. So when she said to put the straps on and listen for fetal heart rate, there is 2 straps. One is the toco transducer and the other is the EFM. So toco transducer is going to display your contraction patterns on a screen. Sometimes they're shooting, you'll see a little paper coming out, and it's easily applied by a nurse and must be repositioned with maternal movement. So anytime mom moves, just make sure it's staying on there. Then you have your external fetal monitoring. So transducer applied to the abdomen of the client to monitor fetal heart rate patterns. So you got one measuring contractions and the other is keeping up with the baby's heart rate so that you know that it's not in distress. So your lab analysis, you're going to look for strep. Cultures obtained if results are not available from antepartum screening. If positive, an IV prophylactic antibiotic is prescribed. Prophylactic meaning before. You give it before. We're going to do UA, clean catch urine sample. Clean catch means that when you go to give this sample, you pee in the toilet first for just a second, and then you put the cup underneath you. Because if you think about gravity, or you're sitting or you're lying, whatever, gravity works. All of like the trash in your urine, if that makes any sense, like, when you pee and it's like really cloudy, you got some trash in there, some junk, all that sitting at the opening. So you want to get that out of the way before you catch that, is how I look at it. Dehydration via specific gravity. So we want to drink a lot of water, but when we do this UA, we're going to see, is it concentrated? Is it watered down? Are they getting what they need? No. Ketonuria, we went through that. That is too much. Ketones in the urine. Proteinuria, which can be indicative of gestational hypertension or preeclampsia. Glycosuria, which can be indicative of gestational diabetes. You can have UTI. We're going to test for that. We're going to test blood tests. We're going to do a CBC level, and we're going to do ABO typing. We give the RhoGAM shot to a negative mom. RhoGAM to negative mom. All right, so client education, you just want to update them regarding the labor. This is what we're doing now. This is where we're at now, that kind of thing. So intra-procedure, now we are in the position to have this baby. We are pushing this baby out. You're going to check maternal vital signs, because we're always checking vital signs. We want to check the temperature every 2 hours if the membranes are ruptured. Why? Because we said if membranes rupture, we are at more of a risk for having an infection. We're going to monitor fetal heart rate. This can be performed by use of the EFM or spiral electrode that is applied to fetal scalp by a registered nurse trained in the procedure or provider. Prior to electrode placement, cervical dilation or rupture of membranes must occur. So before it's literally a screw that they put in the infant's head. Look it up if you haven't looked up, it's nuts. But before you can do that, you have to be dilated, and your membranes have to have been ruptured. So then we have monitor uterine labor contraction characteristics by frequency, duration, intensity, and resting tone. So frequency is, you could test this by putting your hand over the fundus and tell these things. So frequency is from the beginning of one contraction to the beginning of the next. Duration is the time between the contraction and the end of the same contraction. So how long did it last? Intensity is strength. Was it mild, moderate, strong? And it gives you examples of like the pressing feeling, like how it would feel on your finger. Resting tone of uterine contractions. So tone of uterine muscle in between contractions. A prolonged contraction is longer than 90 seconds, or too frequent, that is more than 5 and 10 minutes, without sufficient time for uterine relaxation. So it's not chilling out before it starts doing its thing again. Less than 60 seconds in between, and it can reduce blood flow to the placenta. So it's cutting off supply to the baby, and it's not giving it time to chill out first. Intrauterine pressure catheter. So insertion of a sterile, solid, or fluid-filled intrauterine pressure catheter by the provider or a qualified nurse inside the uterus to measure intrauterine pressure. Displays uterine contraction patterns on a monitor and requires the membranes to be ruptured and the cervix to be dilated sufficiently. So just like we were talking about earlier with the one that they screw into your baby's head, which is just wild to me. All right, so vaginal examination. Okay, somebody in the group me, because it's not loading my YouTube stuff very quickly, somebody tell me when you do not do a vaginal examination. When would you not want to do this? Yes. Okay. when there is bleeding. You're not poking around there, you're not stabbing at it, you're not putting nothing up there. We don't mess with that. All right, so when we do a vaginal examination, we're going to perform digitally, which literally means with your fingers. By the provider or qualified nurse to check for the following: cervical dilation. Is it wide enough? Effacement. Is it thin enough? Descent of fetus through the birth canal. Do you feel a baby's head in there? Fetal positioning, presenting part. Did you just grab a toe or did you grab some hair? Maybe it had hairy toes. I don't know. Membranes that are intact or ruptured. So did you feel some kind of sac around this thing? Is it just free balling it? This is going to tell you whether or not you're ready. Mechanism of labor and vertex presentation. So the adaptations the fetus makes as it progresses through the birth canal, and this, she did say no. You have engagement first, which occurs when the presenting part, usually biparietal, largest diameter of the fetal head, passes through pelvic inlet and at the level of ischial spines, referred to as station 0. Then you have descent. So progression of presenting part, preferably the head, occiput, through the pelvis, measured by station during vaginal examination as either negative station, 0, which is not yet engaged, it hasn't come out yet, or positive, which is past pelvis. So effacement, we're kind of heading down. Descent is where we are, as in negative, zeros, or positives. Flexion is when the fetal head meets resistant of the cervix. So I think I did send a video to the other group because I just got put in this group today, but I will send it to y'all, and it was a very good video. It was like a baby doll in a fake pelvis, and he walked through the stages of this. I was like, oh, okay, that's what they're talking about. It made a lot of sense, and it helped me a lot. So I'll send it to you guys. But flexion is when the head comes down and meets the pelvis, and it starts to turn in. So head flex is bringing chin to chest, presenting smaller diameter to pass through the pelvis. Then you have internal rotation, which it ideally, hopefully, would rotate to a lateral anterior position as it progresses from ischial spines, which is your 0, to the lower pelvis in a corkscrew motion to pass through the cervix. So we're wanting it to kind of turn and go down. Then we have extension, where the fetal occiput head passes under the symphysis pubis and the head is deflected. So why didn't I just put head in there twice? Is deflected anteriorly and is borne by extension of the chin away from fetal chest. So eventually the head is going to come out, and then we're going to have our restitution, which is going to be your shoulders. So restitution, after the head is born, rotates in position. It's occupied as it enters the pelvic inlet. Restitution in alignment with fetal body and completes a quarter turn to face transverse as the anterior shoulder passes through symphysis. That was right. Birth by expulsion. That baby's coming on out. It's just pushing out. After birth of the head, shoulders, trunk, and neonate is born by flexing in towards symphysis pubis. So once you get that one shoulder worked out, the rest of it should kind of swim. We also have, I'm going to jump down to the bottom real quick for characteristics of true versus false labor. So for true labor, keep saying labor, you're going to have cervical dilation and effacement. So opening, thinning, contractions, they can be irregular and become strong and frequent. Stronger, they last longer, more frequent, felt in lower back, radiating to abdomen. Walking can increase contraction intensity. Continue despite comfort measures. Cervix, you need to be checked by a vaginal exam. Progressive change in dilation and effacement. Moves to anterior position, you have the bloody show, and the fetus presenting part engages in pelvis. So post-procedure, this is after your delivery. Vital signs. You're going to look at the fundus. You're going to look at lochia, which is the discharge after. You're going to look at perineum, which we all know what your peri area is. Urinary output, because they're not going to let you go home until you pee. They're going to let you leave until you go to the bathroom. Maternal, newborn, baby-friendly activities. So your actions during this 4th stage is I thought you were saying something. There you go. You want to check their blood pressure and pulse at least every 15 minutes for the first 2 hours after they have that baby. And then you want to check their temperature every 4 hours for the first 8 hours after birth, and then at least every 8 hours. Check the fundus and lochia every 15 minutes for the first hour. So right after they have the baby, you're going to check their fundus, make sure that the uterus is contracting back up to go back to normal per se. And you're going to check lochia, which she said you could measure by pads as to whether or not it was saturated, that kind of thing. We want to massage the fundus because I just lost my place. I literally cannot remember where I just was. You want to massage the fundus because we want it to go back to where it was. If it doesn't and it stays relaxed, this can cause hemorrhage. So we're going to encourage voiding to prevent bladder distension. We're going to promote an opportunity for maternal newborn bonding. So we're going to hand that baby up as quick as we can for skin to skin, and we're going to encourage breastfeeding as soon as we can because this is also going to cause the uterus to contract. Notify nurse of increasing vaginal bleeding or passage of blood clots because they need to know how much has come out. They need to know what it looked like. They need to know if there's hemorrhage going on. So next we're going to look at pain management. And here we are going to end up, we have more medications and stuff, which I did send some stuff to the group earlier. Oh, all right. So the first thing is pain is what the patient says it is. So no matter if you're coming in and your patient's chilling out and they're having a good old time watching TV, laughing, cutting up, and then they're like, oh, my pain's at like a 10. It's the worst pain I've ever felt. And you're like, no, Becky, you're fine. You look fine. You still have to believe what they say. Pain is what the patient says it is. So the first stage of pain that sources of pain during labor, is internal visceral pain that can be felt as back and leg pain. So this is like the very beginning. It's not that super serious, but you're like, this is different. This is uncomfortable. The causes of that would be dilation and effacement, distension of the lower segment of the uterus, contractions of the uterus with resultant uterine ischemia. The second stage is going to be somatic, and it occurs with fetal descent and expulsion. So somatic meaning, I think, like systematic. Your whole body, like everything's going to be not comfortable. And this will be pressure and distension of the vagina and perineum, described by the client as burning, splitting, and tearing. Pressure and pulling on pelvic structures, ligaments, fallopian tubes, ovary, bladder, and peritoneum. So everything is down, pulling. And lacerations of soft tissue, so cervix, vagina, and perineum. And then your third stage is going to be pain with expulsion of placenta. So we have first, I need to go in, I'm having this baby. Second, I've had this baby. Third, I'm getting rid of this placenta. And it'll be uterine contractions and pressure and pulling on pelvic structures. This is what we're feeling this because of. Then your fourth stage is your splitting, burning, or tearing sensation, and that is pain caused by distension and stretching of the vagina. So you done messed it up downstairs, and now everything's trying to go back to normal, and it's going to hurt. So your data collection, do not always look at your patient, what they look like, to determine how they feel. You can't tell a patient how they feel, and you can't guess the patient how they feel. You have to ask. You have to use appropriate charting. Say you had somebody come in that was mentally challenged and had just given birth to a baby, and you're trying to ask them what their pain scale is on. You may have to use a face scale. You may have to approach them differently than you would someone else. So you want to make sure that you know your patient, know them culturally, know them psychologically, so that you can appropriately gauge their pain level so that you can translate that into what they're getting. Know your cultural beliefs, because some cultures don't want to use pain meds and they'll suffer through that, and they may tell you that they're fine and they're not fine, but if they refuse medication, if they don't want to take pain meds, then that's up to them. We need to know that though. Anxiety and fear are associated with pain. Fear and anxiety increases, muscle tension increases, experience of pain increases, and it becomes a cycle of pain. So we got to stop that somewhere. Domino effect. Check beliefs and expectations before they go in. We're going to monitor level, quality, frequency, duration, intensity, and location of pain, verbal and nonverbal cues, and an appropriate pain scale. So indications of pain would be behavioral manifestations, and this is going to be crying, moaning, screaming, gesturing, writhing, avoidance, withdrawal, inability to follow instructions, an increase in blood pressure, tachycardia, hyperventilation. We're panicking, basically. We don't feel well. Nausea and vomiting, that increase in gastric acidity. We're going to help the client maintain proper positioning during administration of pharmacological interventions, meaning if the doctor is about to come in and give your patient an epidural, you want to help keep them in a position where because those are very dangerous. You can give somebody epidural and it can be put in the wrong spot. You can be paralyzed, and that's very, very dangerous to do that. So you have to be careful with your placement. You have to make sure that your patient is staying very still. They're lying in a certain position, and normally they're going to want you kind of leaning off the side of the bed and hunched forward because it keeps the skin taut and it opens. When you do that, it opens the space between the vertebrae so that they can get that catheter in there easier. So, also, while they're doing this, you want to make sure that the bed is in a low position, side rails up, call light and reach, wheels locked. Always, 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 because most of the time when they're giving this, your patient's going to have an abnormal gait. They're not going to be able to walk or walk well because a lot of this stuff is numbing. So you're going to evaluate client's response to pain relief methods. Is it helping? Did they have too much? Did they have too little? Are you seeing signs of adverse effect? You need to be able to watch that, which also we'll get to in just a minute, but you need to have a baseline of your patient's vital signs so that you can tell if something's going awry. So non-pharmacological pain management literally means no pharmacy, no pain meds. This is all distraction, more of a not holistic, that's not the word I'm looking for, I guess, but more of a least invasive kind of thing, I guess. So this is used to reduce anxiety, fear, and tension. And we're going to look at gate control theory of pain. So this is based on a concept that the brain will only allow a limited number of sensations to travel at any given time. By sending alternate signals through these pathways, pain signals can be blocked from ascending the neurological pathway and inhibit brain's perception and sensation of pain. Basically, this is saying there's a concept that the brain can only have a limited number of sensations traveling at one time, like we'll say 10. Okay. By sending alternate signals through these pathways, so rather than medication, we may use aromatherapy. This is saying that pain signals can be blocked from ascending in neurological pathway and inhibit the brain's perception and sensation of pain. So it's pretty much saying once you've reached a level with something else, there is still another way. We're going to bypass that. An assistant understanding of how non-pharmacological pain techniques can work to relieve pain. So a lot of people don't believe in this stuff. A lot of people don't use it. A lot of people say, cut to the chase, give me the meds. And then you have people that really want to try and do it, on their own or less invasively or not so risky, I guess. And so they'll try these kind of things. So the interventions for this will be cognitive strategies, cognitive meaning up here. You need to give your patient education. They need to know what you're doing. They need to know when you're doing it and why. Childbirth preparation methods. So Lamaze is a breathing pattern, that's Lamaze. Pattern breathing exercises promote relaxation and pain management because it keeps you focused on something else other than what is actually going on and the splitting that's happening between your legs. So doulas can assist clients using methods for non-pharmacological pain management. Nursing implications include monitoring findings of hyperventilation because this is caused by low blood levels of PCO2 from blowing off too much CO2, such as lightheadedness and tingling of fingers. So this is if your patient is hyperventilating. You may have them breathe into a paper bag or cup their hands because you're wanting to keep more of that in. I would also know that this is something a little newer than what we've seen in the past chapters. The signs of hyperventilation being lightheadedness and tingling of fingers. So that maybe sometimes they'll do questions like that. Hypnosis, which is pretty cool. I want to try that one day, even if I'm not pregnant. Biofeedback. And then you have your sensory stimulation strategies based on the gate control theory to promote relaxation. So we have aromatherapy, which is actually becoming a pretty popular thing now. Some hospitals are coming around and offering for patients to use that. Like they'll have somebody that comes around like any other, normal thing in a facility, and they'll come by and let you try out different things, smell different things, and see if it relaxes you, if it chills you out. You can use that rather than pain medication. Breathing techniques, the Lamaze, or, when you're meditating and it's telling you to breathe in for a certain amount of time and breathe out for a certain amount of time, those kind of things. Imagery, you're going to go to your happy place. Music, meditation music, use of focal points, pick something and stick to it, pick something and focus on it. Subdued lighting, chilling it out. So a lot of these things can distract you from what's actually going on. Cutaneous stimulation strategies. So therapeutic touch and massage, make sure you know your patient's limits, make sure you know your patient's, cultural beliefs. Some people don't want you touching on them. You need to know that stuff. Walking, rocking, which is movement, and effleurage, light, gentle circular stroking of client's abdomen with fingertips in a rhythm with breathing during contractions. Sacral counter pressure. So this will be like having somebody put down a lot of pressure on your sacral area to counter the pressure that you already feel. Hot or cold application. You have TENS therapy, hydrotherapy, which is like my favorite thing when I go to the gym. Like I don't even care to actually work out when I go to the gym. I just want to sit in the hydrotherapy bed and at the chiropractor's office. So then you have acupressure, frequent maternal position changes. So semi-sitting, squatting, kneeling and rocking back and forth, or supine position only. It's so late, y'all. All right, so client education, use techniques to promote pain management, breathing patterns, progressive relaxation exercises. Then we're finally getting to our medications. So, analgesia and local regional analgesics, we want to, before we give anything, we need a baseline. We always need a baseline, something to go back to, because we won't know if something changes if we don't have a normal. You want to verify that labor is well established by performing a vaginal exam and evaluating uterine contraction pattern. So these alleviate pain sensations or raise the threshold for pain perception. So our first one, analgesia, is our sedatives, which is barbiturates. And I put on a piece of paper, sedated Barb. I just drew a picture of a woman on there. Her name's Barb. So secobarbital, phenobarbital, pentobarbital. These are typically not used during birth, but they can be used during the early or latent phase. So your adverse effects are neonate respiratory depression, because this is a depressant. Should not be administered if birth is anticipated within 12 to 24 hours. So if you are real close to giving birth, we're not taking this. Unsteady ambulation of client, because it's a depressant, so you don't want your patient walking up doing all kinds of crazy stuff. Inhibition of mother's ability to cope with the pain of labor. Sometimes they'll experience apprehension. It'll kind of, essentially they're freaking out, and they'll become hyperactive and disoriented because, I don't know if you ever seen somebody like fight morphine. It's kind of like that. They can't handle it. There's too much going on, and so they'll kind of start doing the opposite of what you'd expect them to do, or just fight it. So medication will cause drowsiness, and you should request assistance with ambulation. You cannot be by yourself after you've taken this. So you're going to dim lights. It should be quiet. It should be safe, low, locked bed and position. Call light within reach. You want to have side rails up. Assist mother to cope with labor. You're still coaching them through this. You're still talking them through it. Monitor the neonate for respiratory depression. We don't want the baby to have issues breathing. Then we have our opioid analgesics. So there was a couple medications in here, but the two that we saw was butorphanol and nalbuphine. So I memorized this as O, nal, my butt don't want me or my baby to have respiratory depression. So O as in opioid, nal as in nalbuphine, and butt as in butorphanol. So these are, they act on the CNS, so your central nervous system, and they decrease perception of pain without the loss of consciousness. So these do not make you pass out. They may make you drowsy, and they may cause you to still need help with ambulation. They're very similar to analgesics, but they have opioid in them. Let's see. The adverse effects would be respiratory depression in neonate. If mother's too close to time of delivery, so we're not going to give it too soon, or too close to delivery. Reduction of gastric emptying, increasing nausea and emesis. So opioids are going to slow you down. Everything is slow. So if your gastric emptying is slower, meaning constipated-ish, you could think of constipation, but everything's slow because it's depressing. It's slowing everything down. Your peristalsis is going to be slow. So if you're doing that, if it's slowed and kind of backed up a little bit, and say you're eating, drinking stuff, it's going to increase your risk for nausea and emesis. Now you still have all that sitting inside of you. Now you're not processing it as quickly as you did before. Now you have increased risk for aspiration or fluids and foods from the stomach because it's not processing and going through as quickly as it would have before. So bladder and bowel elimination can be inhibited. You can have sedation, tachycardia, which is your body trying to compensate, hypotension, low blood pressure because it's a depressant, decreased fetal heart rate viability, and allergic reaction. So your job as a nurse would be to verify that labor is well established and perform vaginal exam by a qualified nurse, meaning make sure it's in your policy. Administer antiemetics, which is the next medication we're going to look at because of the gastric emptying slowing. Excuse me, I haven't eaten anything, so I have hiccups. Let's see, you're going to monitor vital signs, contraction pattern, and fetal heart rate monitoring as usual. You're going to look for adverse reactions, specifically difficulty breathing because they may be having an allergic reaction to this, and we need to get on that real quick. So with any kind of opioid, ever, you want to have naloxone, which is Narcan, to reverse the effects of this. So if your patient is being affected by this negatively, it's gone too far, you can give them Narcan and bring it back out. So our next medication is metoclopramide, and this is for nausea and anxiety. The adverse effects for this will be dry mouth and sedation because it's drying everything up. So you want to give your patient ice chips or mouth swabs. If they can't have like a lot of fluid right now, you give them mouth swabs, and you want to provide safety measures for the client. Your epidural and spinal regional is analgesia. Ooh, excuse me. Okay. Contain analgesics such as fentanyl, sufentanil, and these are short-acting opioids. So these are administered as a motor block into the epidural or intrathecal space. I said it right. Intrathecal space without analgesia. So intrathecal space just means like in your spine. These opioids produce regional analgesia, providing rapid pain relief while still allowing the client to sense contractions and maintain ability to bear down. So they still have control over some things. It's just not as bad as it was before. So you're going to have slow GI once again, which means you have resulting nausea and vomiting and chance for aspiration. Slow pee-pee poo-poo. Everything slow down. Bradycardia or tachycardia, depends on if your body's trying to compensate. Low blood pressure, low respiratory rate. You can have allergic reaction or pruritus, which is itching, which we know if you're itching, most of the time it is an allergic reaction, something, and elevated temperature. So your nursing actions are going to be safety precautions. You're going to make sure the bed's in low slot position. You're helping your patient to the bathroom. You're putting up the bed rails. They have a call light within reach. You're going to monitor for nausea and vomiting. Look at their vital signs, make sure they're not having an allergic reaction. So then we have pharmacological anesthesia, and there's two kinds. We have regional and general. Well, regional has 3 different types. So these are the most commonly used and consist of pudendal, epidural, spinal, and paracervical nerve block. So your pudendal block is basically numbing everything at the bottom, if that makes sense. So it's a local anesthetic like lidocaine, and I will give you a terrible example of this, and I'll be super upset if you guys don't remember it. Lidocaine and bupivacaine. So these are administered transvaginally into the space in front of the pudendal nerve. Has no maternal or fetal systemic effects. So it's not going to affect your whole body, and it's not going to affect the baby's whole body. It's local anesthesia to perineum, vulva, rectal areas during delivery, episiotomy when they cut you, and episiotomy repair when they're fixing it. So this is administered during the late second stage of labor, about 10 to 20 minutes before delivery. So prior to spontaneous expulsion of the fetus or forceps assisted or vacuum assisted birth, which we'll get to later, and is suitable during second and third stages of labor and for repair of episiotomy and laceration. So referring back to the chart on 73, where I sent into the group a picture, I would know the stages and when you can give what. So adverse effects are going to be compromise of maternal bearing down reflex because she won't be able to feel that. That's where you feel is the opening. And you're going to need to coach the client when to bear down. You also need to let them know what's going on with the procedure. So when you think of the pudendal block, which is a regional block, regional meaning like a small area, you can think of me because I've had one of these before in that same area. I was like way older, way married, way had been having sex through this part of my life, and my hymen never broke. And they had to go in and break it for me. So they gave me this kind of block just because it didn't need to knock me out. It didn't need to affect my whole body. It was just that one area that needed to be numb. So they used lidocaine. So when you think of the pudendal block, remember me and how gross that was and how not fun one that was. So usually it just numbs down low for external genitalia. And that's for just like sewing you up, and it's at the very, very end. So then you have your epidural block, which is also a regional. And this is consisting of a local anesthetic, bupivacaine, along with an analgesic, morphine or fentanyl injected in the epidural space at the level of 4th and 5th vertebrae. Mainly what you need to know about this is that it numbs you from the belly button to the thighs. Might not remove pressure sensation, so you might still like feel pressure, but you're not like dying. And you have to be actively in labor and dilated at least 4 centimeters before they will give you this. And it's usually a continuous infusion or intermittent, like meaning on and off. And sometimes they'll give it to you as patient controlled. So sometimes you can push this on your own. It's suitable for all stages of labor and types of birth and for repair of episiotomy and lacerations. So the adverse effects will be mom has a low blood pressure, fetal bradycardia, meaning it's slowed down, fever, itching, which is a signification indication of an allergic reaction, inability to feel the urge to void or urinary retention. So if you're numb from the belly button down to the thighs, you're not going to be able to feel if you need to go to the bathroom, and you're not going to be able to feel if you're holding in too much urine and you need to go. Loss of bearing down reflex, because we can't tell when we're supposed to do this. So we need to have our nurse tell us when to bear down. So you are going to help with the administration of bolus and IV fluids. We don't give a bolus, we assist in bolus. Help position and steady the client into a sitting or side lying, modified Sims position with their back curved so that we can widen the spaces between the vertebrae. Remain in side lying position. Don't lay on your back if you can help it, because we're keeping the pressure off vena cava. We are going to coach them in their pushing efforts. We're going to monitor fetal heart rate patterns. We're going to monitor the IV line, oxygen and suction need to be available. Monitor for orthostatic hypotension, which we know is moving positions too fast. Then they may give ephedrine, which treats breathing issues, or increase the rate of IV fluid administration. So we want to keep them safe, bed rails, wheels locked, call light, assisting to go to the bathroom, that kind of stuff. And then I put on here, don't stand until sober. So until this wears off, you don't want to be trying to get up and walk around, because that's super dangerous. All right, so then we have spinal anesthesia block, which is local anesthetic injected into subarachnoid space in the spinal fluid in 3rd, 4th, or 5th lumbar interspace, alone or in combination with analgesics such as fentanyl, and it eliminates the sensation from your nipples to your feet. So we're basically going up here. So we went from just your perineal area to umbilicus to thighs, from nipples to feet. So it's commonly used for cesarean births, and a low spinal block can be used for vaginal birth, but is not used for labor. It's usually administered in late 2nd stage or before cesarean birth. So we're going to monitor for the adverse effects, which is mom has a low blood pressure. We have baby with a low blood pressure. Loss of bearing down reflex, because everything's numb from your nipples down to your feet. So you're going to be able to know when you need to push. We're going to help with that. Higher incidence of maternal bladder and uterine atony following birth. So basically, uterine atony, however you want to say it, is your uterus doesn't contract. So we don't feel that. We don't feel when something's wrong. So there's more of a chance that your bladder is going to have an issue, because you can't feel when you need to pee, you can't tell when you're holding it. And then uterine atony, because it's not going to contract back. Normally we can tell when something's wrong with our body, and we won't be able to do that. So your nursing actions, vital signs every 10 minutes, manage the hypertension, which I don't know if they've taught you. I think they taught us this in like CNA school. If you have somebody whose blood pressure has dropped significantly, you always want to ask the physician first, but sometimes you can do Trendelenburg, which gets their blood pressure, pulls the blood back towards your head. It's going to raise your blood pressure if it's really low. Let's see. You want to look for signs of manifestations of impending birth. Manifestations of impending birth means you're going to look for signs that this baby's coming right now. Meaning sitting on one butt cheek because you're trying to displace the pressure, grunting sounds, or bulging of perineum. That means something's trying to get their way out. Potential headache from leakage of cerebrospinal fluid. So if you have a leak of cerebrospinal fluid, like the telltale sign of that is that you have a headache. So what you're going to do for this is you're going to place the client in supine position, promote bed rest in a dark room. Sometimes you can give oral analgesics, caffeine, fluids, and an autologous blood patch is the most beneficial. And this is pretty cool if you've ever YouTubed that as well. Miss McGee, you told us about it a long time ago. They take your blood like from your arm, and then they'll put it into the same place that they just had your epidural at, and it just blocks it. So it keeps it from continuing to leak. You're going to have your patient bear down for expulsion of fetus because during vaginal birth, contractions will not be felt. We're telling them when to push. It is rarely used for vaginal or cesarean births where there are no complications present, and used only in the event of delivery complication or emergency where there's a contraindication to nerve block, analgesia, or anesthesia. And this does produce unconsciousness. So when it says general anesthesia, it's confusing because I think like a general area, but general means like think big, like the whole body. So when you have a general anesthesia, like you're knocked out. So like I'm going to have a kidney removed, general anesthesia, that kind of thing. So this is usually like in a super, super big emergency, maybe like I'm thinking car accident is what I feel like. But that's when you would need something like this. You're not going to be just numb from the belly button down. Monitor vital signs, fetal heart rate patterns, NPO, because it's the same as when you have any other surgery. You're not going to eat anything before you go in. Make sure their IV stays in place, anti-embolytic stockings or sequential compressing devices because we want to avoid clots. Pre-medicate with oral antacid to neutralize acidic stomach contents because we don't want anything coming up while we're doing this. And then we're going to administer a histamine to receptor antagonists. Like ranitidine, which is actually discontinued. That was like my favorite heartburn medicine, but it was shown that it was proving a lot of cancers, so they took it off the market. Not happy about that. But you want to give them something like that. And then you can also give them the metoclopramide, which we did talk about earlier, and that's the antiemetic. You want to put a wedge under them to displace their uterus because we want to get that pressure off. You're going to monitor for ABCs. You want to make sure they have an open, patent airway at all times. Monitor for a postpartum or decreased uterine tone because if we're wanting to make sure that they're not having a hemorrhage, we're wanting to look for that. So I had another word earlier. Okay, if they have a decreased uterine tone, this is also the uterine atony that we just talked about a minute ago. So for client education, we want to do skin to skin as soon as we can while we're dealing with the rest of the stuff downstairs. So we're very near the end of this. The rest of the stuff is like super self-explanatory. But the external cephalic version, I literally just think outside head positioning. So this is with an ultrasound, moving a baby with your hands at 37 to 38 weeks. So we're going to use the ultrasound as a guide, but we're going to use our hands to make sure this baby is positioned in the way that it needs to be positioned. And that's going to be between 37 and 38 weeks. Why? Because we're nearing the end of this pregnancy, ready to get this sucker out. So if your baby is malpositioned, like in a breech or transverse position, we're going to move them around. Easy peasy. All right, Bishop score. This is the mom ready to have this baby? Basically, we're checking out the whole situation, getting ready to move out. We're going to look at dilation, effacement, the consistency, the position, and station at presenting part. So what are we seeing? Are we seeing a head, foot, arm, leg, whatever? 5 factors are assigned a numerical value of 0 to 3. and totally calculated, it needs to be 8 or more. If this is 8 or more at 39 weeks, we are good to go to have this baby. So induction of labor is on purpose. We are purposely making this person go into labor, whether it is chemically or mechanically. So mechanical or chemical procedure approaches administration of IV oxytocin, because that's going to stimulate contractions, and then nipple stimulation to trigger the release of endogenous oxytocin. So endogenous meaning from you, oxytocin that you already have in your body, because we can also administer it, but you do have it inside of you already. So we need it at least to be 39 weeks. You need to, sometimes they'll do it if you're greater than 42 weeks, like your baby's been baking too long, we got to get the sucker out. This is when we would have an induction of labor. Dystocia, sorry. This is prolonged difficult labor. So you've been in labor for a really, really, really long time. So you've been in there for like 72 hours and this baby's not budging, it's not coming. You will have to do something to induce that, make it happen faster. Let's see, prolonged rupture of membranes. It's taking a long time for this water to break. It's maybe coming out a little bit at a time. We're going to get this sped up. We're going to induce. So maternal medical complications. RH, isoimmunization, diabetes mellitus, pulmonary disease, gestational hypertension, and then fetal demise means stillborn. So if you have a baby, you almost made it to term, you lost the baby, stillborn, they have to induce to get that baby out because your body's not going to do its thing. And then we have the chorioamnionitis, which is the infection of your amniotic fluids, as we said before. So you want to make sure that they are dilated. That's what cervical ripening is. They have to sign an informed consent before we can induce. You need a baseline data before we induce. And let's see. If they are going to use cervical ripening agents, which means something that will send you into, can make you start having labor sooner, you need to consent for that. And they're usually prostaglandins, which we talked about earlier. The medications to stop contractions are going to stop prostaglandins, and that's what you're using to get this baby out. So we're going to monitor for uterine tachysystole or fetal distress, meaning like your uterus is just panicky. So assist with preparation for misoprostol administration, and misoprostol is a prostaglandin. It's just a different way of saying it. So I think misprostaglandin, like Mrs. Prostaglandin, and prostaglandin, same thing. Assist with prepping client for oxytocin administration. Why? Because we want them to get this baby out. Confirm that the fetus is engaged in the birth canal at a minimum of station 0. So pretty much about to be hanging out before we can give this. Let's see. All right, initiate oxytocin no sooner than 4 hours after administration of misoprostol and 6 to 12 hours after dinoprostone gel installation or removal of a dinoprostone insert. So misoprostol, prostaglandin, dinoprostone, they're all the same thing, just different names. All right, when oxytocin is administered, check maternal blood pressure, pulse, and respirations every 30 to 60 minutes. We're going to monitor heart rate, contractions every 15 minutes in the first stage, every 5 in the second. And anytime you change a dosing in something, so if you upped prostaglandins and if you lowered them, you want to go ahead and check that stuff to have your baseline the same. Ensure the Bishop score before you give anything, and discontinue oxytocin if uterine tachysystole occurs. So if they're having very, very quick contractions, you're going to discontinue oxytocin because you're going to end up having a prolapse. So contractions should be no more than 2 minutes and no longer than 90 seconds. She has said that before. I do remember seeing that before. It's there. And if you see, if it's more than that, then it's uterine tachysystole. Also, if there's no relaxation from the contractions, it's tachysystole. Let's see. All right, so the complications of this, the complications of being put into an induction of labor, would be non-reassuring fetal heart rate. So abnormal baseline less than 110 or greater than 160, loss of variability, late or prolonged decelerations, which we talked about a lot. So you want to notify your RN, put them on their side, keep the IV line open, O2 by face mask at 8 to 10 liters per minute. Tocolytic terbutaline, 0.25 milligrams. This stops contraction. So if we're giving too many prostaglandins or we're giving too much oxytocin and causing a contraction, if they're in tachysystole and they're contracting too much, we'll give the tocolytic terbutaline to stop it or to slow it down anyway. So we're going to monitor fetal heart rate. We're going to monitor the mother's responses. How's she handling it? Is she good? She ain't passing out. We're good. If unable to restore reassuring fetal heart rate, we have to prepare for C-section. So augmentation of labor is stimulation of hypnotic contractions once labor has spontaneously begun and progress is inadequate. So we have contractions already, but they're not consistent. It's an abnormal pattern. So we're going to give this. So some providers favor active management of labor to reestablish effective labor with aggressive use of oxytocin or rupture of membrane. So we're kind of helping them along. And all of the risk factors are the same for induction. So I'm not going to go back over those. So amniotomy is basically when they purposely rupture your fluids ahead of time. So they can use a hook, a clamp, or some other kind of sharp instrument, and they're going to get rid of that. Begins within 12 hours after membranes rupture, your labor will start. So usually after 12 hours after they pop that thing open, you're going to go into labor. It can decrease the duration of labor by up to 2 hours. So you might have had a really, really long labor and they probably just shortened it by 2 hours. So with this, though, you have a risk for cord prolapse or infection, and if your progression is too slow. So if they ruptured that and it's taking you a long time to have this baby, you can have a prolapse in your cord, meaning it comes out, or you can have compression on it, meaning that your baby's not getting what they need. So if this happens, they can do an amnio infusion for the cord compression. So all this is doing is putting lactated ringer in the fluid to build it back up so that you don't lose that. You need the fluid to keep off of the cord. So your considerations going in are, is the fetus engaged prior to the amniotomy? You need to monitor fetal heart rate. You need to monitor document characteristics of the fluid, color, odor, consistency. Look at the fluid. What time did it rupture? What is your patient's temperature, and are they comfortable? We want to make sure that we're moving them frequently and that we're keeping them clean because they are having a bunch of junk come out. All right, then we have the amnio infusion, which is what we just talked about a second ago. If you need to add more fluid to it for some reason, you can put normal saline or lactated ringers in the sac. So the reason why we would do this is if our patient had too little amniotic fluid, if if there's intraplacental insufficiency, meaning it didn't develop right, you would add more, or post-maturity to the fetus. So it baked too long and there's not enough, stuff in there, you can add more to it. Fetal cord compression, secondary to fetus, microsomic, or large body. So you got a big, big baby too. Variable deceleration from cord compression, cord is pressed, baby's too big. All right, so now we're at the delivery, how we're getting this baby out. You got vacuum-assisted delivery. Basically, you're sucking the baby out with this cup-like suction device. So they're going to stick it to the baby's head, and they're going to suck, and it's going to pull. So it's during contractions for the descent. So each time they have a contraction, you suck. Conditions for use. So when we would do this would be when there's vertex presentation, meaning the head's down, cervical dilation of 10, absence of cephalopelvic disproportion. So when your baby has a big head, and ruptured membrane. So the water has to break before they can start sucking on stuff. Risks of this could be scalp laceration, so it could cut the baby's head. It could cause subdural hematoma, which is when you have a busted blood vessel deep in your brain. And then it could cause cephalohematoma, which is a blood buildup under the scalp, so like closer to the edge. It can also cause maternal lacerations in the cervix, vagina, or perineum, so it can mess you up too. So you would use this when the mom's too tired to push, she doesn't have any more in her, she's exhausted, when there's fetal distress in the second stage of labor, so they need to hurry up and get this baby out. They're going to use everything they can to pull it. Generally not used to assist birth before 34 weeks, so don't do this before 34 weeks. So you need to educate your client as to what's going on. This is what we're about to do. This is what you're about to feel. You need to have them in a lithotomy position, which is legs on the stirrups, like you would when you're at the gynecologist. And you want to check for the fetal heart rate baseline and bladder distension. Make sure you're giving postpartum care. Monitor neonate for lacerations, for the hematomas. Was there anything wrong? Check this baby over when it comes out. And then monitor neonate for capitum succedaneum, which is swelling of the scalp. So if they did, have you ever seen like cupping on your back, like videos of that? It's kind of like that, but on your head. So you may have like a little bruise area up there. You might be a little swollen, but it should go down after 3 to 5 days. So then we have our salad tongs, which is our forceps assisted birth, which my mom said they did with me. They did not tell her what they were doing the first time that she felt the cold touch her. She said, "What the hell is that?" Nobody told her what they were doing. She had no idea what was going on. But they were using like metal salad tongs to pull my head out. Maybe that's what's wrong with me. So you're going to want to use these when your patient is in the second stage, mom is too tired to push, when their fetal baby's in distress, or when they're breech or other. Baby stops rotating. So this is, we need assistance. We need it now. Sorry, the cat jumped outside. It scared me. All right, so considerations. You want to educate. Lithotomy position. Is the bladder empty? Is it distended? Is the fetus engaged? Fetal heart rate. You want to do it before, during, and after the forceps are used. You want to, if fetal heart rate decreases, if the baby's heart rate is decreasing, you're going to take the forceps off and then you'll reapply, because maybe you just had them grabbed in the wrong place. Maybe it was just, hurt, affecting it that way. So you're going to monitor for facial palsy, which is like a weakness, or like one side's not as strong as the other. Monitor for urinary retention, vaginal or cervical lacerations, hematoma around the mom's area, and reinforce postpartum nursing caregivers. So you need to let somebody know afterwards, like if they have somebody at home taking care of them, hey, this is what happened, this is what we used, you need to be looking for this. Complications could be lacerations of cervix. You can stab around in there and cut something with those. Lacerations of vagina and perineum, injury to bladder, facial nerve palsy of neonate, facial bruising of neonate, subdural hematoma of neonate. So lacerations, you got a 1st degree, 2nd degree, and 3rd degree. First is through the skin and perineum and does not involve muscles, so it's pretty light. Second is skin, muscles into perineum, but not the anal sphincter. Third is skin, muscles, perineum, and anal sphincter muscle. Fourth is skin, muscles, anal sphincter, and anterior rectal wall. So the higher up you go, the more you're messing with. Episiotomy, this is when they cut you, and it can either be they know it's coming, sometimes you rip, sometimes they don't make it to it. So they use it to shorten the second stage of labor, to facilitate forceps-assisted or vacuum-assisted delivery. So if you're going to use the forceps or you're going to use the vacuum, it will probably be easier if you had more space, so they'll go ahead and snip you. Prevents cerebral hemorrhage in a fragile preterm fetus. So if you don't want to be squeezing and scratching and pulling and stuff, they just widen the opening, makes it easier. And if you have a large baby, they want to cut that, or you'll rip. All right, so the considerations, you have a medial or median midline episiotomy, and then you have a mediolateral. So median or midline just means it's going to be straight up and down. It's most effective, most commonly used, easily repaired, generally the least painful because it's a clean cut, and it's associated with higher incidence of 3rd and 4th degree lacerations, which if we look back up at lacerations is uncomfortable. Mediolateral episiotomy, which is instead of, down, we're going to one side or the other, depending on where the head is at usually. Third-degree lacerations can occur and blood loss is greater and the repair is more difficult and painful because then you're kind of moving over towards muscle because that's usually like a skin kind of thing. So encourage alternate labor positions to reduce pressure on perineum and promote perineal stretching to reduce the necessity for an episiotomy. So then we have C-section or cesarean birth. We're going to make a trans-abdominal incision vertically and horizontally into the lower segment of uterus. Horizontal is the optimal incision. So this way. Used when there's malpresentation, baby's not coming out right, breech. Cephalopelvic disproportion, baby's got a big old head. That's what that means. Non-reassuring fetal heart tones, they're in distress. Placental abnormalities, either it's detached or it's blocking the uterus. If your patient has HIV, if they have hypertensive disorders, preeclampsia or eclampsia, diabetes, or genital herpes, you're going to have a C-section because these things can be passed on to your baby, and sometimes it's too stressful for them to have the baby. If they've had a previous C-section, if they have dystocia, multiple gestations, umbilical cord prolapse, meaning it came out, congenital malformations, or maternal cardiac and respiratory disease. These will be reasons why you would have a C-section. So pre-procedure, you want to monitor and record fetal heart rate and vital signs. You want to give an ultrasound, supine position and wedge under the hip, indwelling catheter, informed consent form, sequential compression device when it went through a clot, administration of preoperative medication. Sometimes they'll give you like an antibiotic or something since they're cutting you all the way out open. Prepare surgical site, IV catheter, initiation of IV fluids, NPO the night before the procedure unless it's an emergency and you can't do that. RH factor test because this baby's about to come out. We need to know, have you had it? Have you not? Are you negative? Are you positive? Reinforce procedure and provide emotional support because it's a surgery. It's scary. People get freaked out. So post-procedure, monitor for infection because you just got cut open. Are you bleeding excessively? Check the uterine fundus, firmness or tenderness. Are we contracting back up or are we about to hemorrhage? Lochia for amount and characteristics. Tender uterus and foul-smelling lochia can indicate endometriosis, endermatitis, Monitor for productive cough or chills, which can be a manifestation of pneumonia. We want to look for indications of thrombophlebitis, tenderness, pain, heat on palpation, eyes and O's, vital signs, pain relief, antiemetic, turn, cough, and deep breath. That's Miss McBride's favorite thing. Encourage splinting of the incision with pillows. So after you've been cut up, you may want them to hold a pillow so if they cough, they're not pushing everything out. They don't have an evisceration of the wound. Monitor for burning and pain during urination because this could be urinary tract infection. So complications of a C-section would be aspiration, amniotic fluid, pulmonary embolism, wound infection, wound dehiscence is when it opens up and everything comes out. Severe abdominal pain, thrombophlebitis, hemorrhage, UTI, injuries to bladder or bowel, anesthesia associated with complications, and premature birth of fetus if gestational age is inaccurate, fetal injuries during surgery. So then we have vaginal birth after cesarean. So you've had a C-section and now they're wanting you to have a vaginal birth because this is the criteria for the VBAC. No other uterine scars or history of previous rupture, 1 or 2 previous low transverse cesarean births, clinically adequate pelvis, clients who have had prior cesarean for dysfunctional labor, breech presentation, or abnormal fetal heart rate pattern, which are considered non-reoccurring events. You want to give it immediately available throughout active labor, capable of monitoring labor and performing an emergency C-section if necessary. If there's no current contraindications, if they're too large, if their head is too big, if they're blocking, something's in the way, cephalopelvic disproportion, previous classical vertical uterine incision. So depending on how you were cut before and how you healed before, that scared the mess out of me. All right, so pre-procedure before a VBAC is you want to check and see if they had previous low segment transverse cesarean incisions. And then you want to reinforce the procedure with the client and their partner. So you want to let them know what's going on, how we're going to proceed through this. So post-procedure, we're just going to do interventions for vaginal delivery after C-section, the same as vaginal delivery. We're looking for the same stuff. Hemorrhage is like your big thing. So complications related to labor process require immediate attention. Prolapsed umbilical cord, is it displaced? Is there a presenting part of the fetus protruding through the cervix? Is there cord compression and compromised fetal circulation? Risk factors for prolapsed umbilical cord would be rupture of amniotic membranes, abnormal fetal presentation, like it's coming out the wrong way, transverse lie, so they're laying like this, mom's like this, that's not going to work. Unusually long umbilical cord, multifetal pregnancy, engaged presenting part, or polyhydramnios. Polyhydramnios is the same as hydramnios. They just use a different word. It literally means the same thing. Actually, polyhydramnios means more fluid. So your expected findings, you'd be feeling something coming through the vagina. Like you are going to know if there's an abnormally large spaghetti noodle coming downstairs. Visualization or palpation, you can feel it. Fetal heart rate is going to show prolonged deceleration, and then excessive fetal activity following a cessation of movement. So stops for a second, and then it'll be like wild, stop, wild. It's suggestive of severe fetal hypoxia, which is a cutoff of oxygen. Call for assistance immediately. Notify provider. Sterile glove hand, 2 fingers in the vagina. Apply finger pressure on either side of the cord to the fetal presenting part to elevate it off of the cord. We want to keep pressure off of it. Knee to chest position, Trellendenberg, or side lying with a towel rolled under the client's left or right hip to relieve pressure on the cord. So warm, sterile, saline-soaked towel to the visible cord to prevent drying and to maintain blood flow. Same thing for if you have an evisceration. You want to cover it with sterile fluid. Continue monitoring. You want to give them oxygen at 10 liters. Assist in IV, immediate vaginal birth if cervix is fully dilated, or cesarean section if it is not. So if they're not really dilated very much and it's hanging out, you may want to do C-section to hurry up and get that baby out, because they can't have that cutoff of oxygen for so long. All right, meconium stained amniotic fluid. This is when the baby poops inside of you. And it's going to be a increase for incidence around after 38 weeks, because the baby's growing, it's more physically fit to do these things. Umbilical cord compression is going to cause hypoxia and stimulates vagal nerve, which is in your anus. It's going to make them want to go to the bathroom. Hypoxia stimulates vagal nerve, which introduces peristalsis of the fetal gestational tract and relaxation of anal sphincter. So they're going to do this, and it's going to cause an infection. They're going to be breathing that stuff in. So usually it will be black to greenish, yellow or brown, often green. It can be thick or thin, often present in breech presentation and might not indicate fetal hypoxia. Present with no changes in fetal heart rate, and stained fluid accompanied by variable or late decelerations. So this is like an ominous sign, meaning the most telltale sign. You're going to look at electronic fetal monitoring. You're going to note and report color and consistency of stained amniotic fluid for your patient, and you're going to look for fetal distress. Sorry, this is a different thing. So fetal distress is present when fetal heart rate is below 110 per minute or above 160 per minute. Shows a decrease or no variability, like no changes, no bouncing, and there's no fetal hyperactivity or no fetal activity. So then we know that there's something wrong, the baby's in distress. We're going to, if you have fetal anomalies, meaning your baby has some kind of issue, this is more likely. Uterine anomalies, something's wrong with your uterus, we'll see this, or complication of labor and birth. Maybe it took a long time or something. Expected findings, non-reassuring fetal heart rate pattern with decreased or no variability. Your diagnostic procedures are going to be uterine contractions, monitoring that, monitor fetal heart rate, and monitor findings of ultrasound and other diagnostic tests. And last but not least, your nursing care is going to be monitor vital signs and heart rate as usual for the fetus. Position client left side lying, administer 8 to 10 liters of oxygen, oxytocin stopped, and prepare to assist with increasing IV fluid rate, and prepare for emergency section for birth. And that is 8 through 10. And we made it right under 3 hours. All right. Well, I am going to bed. If you guys have any questions, you can send them in the group me, and I'll be happy to look at it for you. And then tomorrow, if you guys want to do this tomorrow, we can go over 11 through 13, which should not be quite as long. Yeah, I think it's actually shorter. So, all right, bye.